Hello everyone, and welcome back to another chapter of Advanced Pathophysiology. Today we are discussing chapter 22, Alterations of Hormonal Regulation. This is going to be a big one. So I think with everything that's going to be covered on here, we jump right into it. The function of the endocrine system involves complex interrelationships and interactions that maintain dynamic steady states, provide growth and reproductive capabilities, and allow for adaptive changes in time of stress. Alterations in function are caused by either hypersecretion or hyposecretion of various hormones, leading to abnormal hormone concentration in the blood and abnormal receptor function, or from altered intracellular response to the hormone receptor complex. Your mechanism of hormonal alteration. Significantly elevated or depressed hormone levels may result from a variety of causes. Dysfunction of an endocrine gland may involve the gland's failure to produce adequate amounts of biologically free or active hormone forms, your hyposecretions. This failure may occur when the secretory cells are unable to produce or obtain an adequate quantity of required hormone precursors, or when they are unable to convert the precursors to the active hormone. Once hormones are released into the circulation, they may be degraded at an altered rate or inactivated by antibodies before reaching the target cell. Other causes of decreased hormonal delivery to the target cell include an inadequate blood supply to the gland or target tissues, or an abnormal amount of appropriate carrier proteins in the serum. A gland also may synthesize or release excessive amounts of hormone, hypersecretion. For example, feedback systems that recognize the need for a particular hormone may fail to function properly or may respond to inappropriate signals. Ectopic sources of hormones may result also in abnormally elevated hormone levels without benefit of the normal feedback system for hormonal control. In these cases, the ectopic hormone production is said to be autonomous. There also may be alterations in the expression function of hormone receptors, thus affecting hormone action. So box 22.1 here, the mechanisms of hormone alterations. You see inappropriate amounts of hormone delivered to a target cell and the inappropriate response by the target cell. So I'll leave that up as I keep going. Target cells may fail to appropriately respond to hormonal stimulation. Hormone insensitivity. Two general types of target cell insensitivity to hormones are cell surface receptors associated disorders and intracellular disorders. Your cell surface receptor associated disorders. These disorders have been identified primarily in water-soluble hormones, such as insulin. They may involve a decrease in the number of receptors, leading to decreased or defective hormone receptors. Binding and impairment of receptor function resulting in insensitivity to the hormone, presence of antibodies against specific receptors that either reduce available binding sites or mimic hormone action suppressing or exaggerating respectively, the target cell response, or unusual expression of receptor function as occurs in some tumor cells. Intracellular disorders. These disorders involve acquired feedback or defects in post-receptor signaling cascades or inadequate synthesis of a second messenger, such as a cyclic adenosine monophosphate, your CAMP, needed to transduce the hormonal signal into intracellular events. The target cell for water-soluble hormones may have a faulty response to hormone receptor binding and thus fail to generate the required second messenger, or the cell also may have an abnormal response to the second messenger if levels of intracellular enzymes or proteins are altered. As a result, the target cell fails to express the usual hormonal effect. So your pseudo-hypoparathyroidism under hypoparathyroidism. Your pathogenic mechanism affecting target cell response for lipid-soluble hormones, such as thyroid hormone or glucocorticoids, are less recognized, less often than those affecting the water-soluble hormones. When they do occur, the mechanisms are similar to those for water-soluble hormones, including changes in their number and binding affinity of intracellular receptor or altered generation of new messenger ribonucleic acid, your mRNA, and substrates for new protein synthesis. In other cases, hormone responsiveness may be linked to alterations in nuclear co-regulators or transcription factors, which are proteins that facilitate or inhibit the transcription of target genes. Alterations of the hypothalamic-pituitary system. Perhaps the most common cause of apparent hypothalamic dysfunction is interruption of the pituitary stalk, which can be caused by destructive lesions, rupture after head injury, surgical transection, or a tumor. In these cases, the absence of hypothalamic releasing or inhibiting hormones cause a variety of manifestations that present clinically as pituitary disease. For example, if there is an absence of gonadotropin-releasing hormone from the hypothalamus, then there is a lack of stimulation of gonadotropin follicle stimulating hormone and luteinizing hormone from the pituitary. Thus, menses cease in women and spermatogenesis is impaired in men. Adrenocorticotropic hormones response to low serum cortisol level is decreased because of the absence of corticotropin-releasing hormone. Hypothalamic hypothyroidism is caused by the absence of the thyrotropin-releasing hormone. Low levels of growth hormone-releasing hormone result in growth hormone deficiency and growth failure, or growth failure in children. Hyperprolactinemia is caused by an absence of usually inhibitory control of prolactin secretion by dopamine. So here we see the loss of the hypothalamic hormones. So if there is a decrease in the hypothalamic function, there's going to be that decrease in the anterior pituitary gland. Decreases of the posterior pituitary. Diseases of the posterior pituitary usually cause abnormal secretion of antidiuretic hormone. An excess amount of this hormone results in water retention and a hypoosmolar state, whereas deficiency in the amount of response to ADH results in serum hyperosmolarity. Changes in both ADH and oxytocin release and function are increasingly linked to changes in social behavior, particularly during stress. Thus, these complex pathophysiologic states not only have significant clinical effect on the modulation of body fluids and electrolytes, but also affect cognitive, emotional, and behavioral responses to stress. Syndrome of inappropriate antidiuretic hormone secretion, or SIADH secretion, is characterized by high levels of ADH and the absence of normal physiologic stimuli for its release. A common cause of SIADH is the ectopic production of ADH by tumors, such as a small cell carcinoma of the duodenum, stomach, and pancreas, cancer of the bladder, prostate, endometrium, lymphomas, and sarcomas. Pulmonary disorders associated with SIADH include pneumonia, small cell carcinoma, asthma, cystic fibrosis, and respiratory failure requiring mechanical ventilation. Central nervous system disorders that may cause SIADH include encephalitis, meningitis, intracranial hemorrhages, tumors, and trauma, including neurosurgery. A nephrogenic form of SIADH involves an X-linked mutation in arginine vasopressin gene leading to chronic activation of tubular V2 receptor and resulting in excessive free water reabsorption and concentration in urine. Any surgery can result in an increase in ADH secretion for as long as 5 to 7 days. The precise mechanism is uncertain but is likely related to fluid and volume changes following surgery, the amount and type of intravenous fluid given, and the use of narcotic analgesics. Transient SIADH is especially common after a pituitary surgery because stored ADH is released in an unregulated fashion. Medications are an important cause of SIADH, especially in the elderly. These include hypoglycemic medications, antidepressants, antipsychotics, narcotics, general anesthesics, chemotherapeutics, nonsteroidal anti-inflammatory drugs, and synthetic ADH. These drugs either stimulate ADH release, enhance the physiologic effects of ADH, or have a biologic action similar to that of ADH. Again, ADH, antidiuretic hormone. So what is the pathophysiology? The pathophysiology features of SIADH are the result of enhanced renal water retention. ADH increases renal collecting duct permeability to water by inducing the insertion of aquaporin-2, a water channel protein, into the tubular luminal membrane, which increases water reabsorption by the kidneys. This results in an expansion of extracellular fluid volume that leads to dilutional hyponatremia, hypoosmolarity, and urine that is inappropriately concentrated with respect to serum osmolarity, because water is reabsorbed that normally would be excreted. So what kind of clinical manifestations do we then suspect to see in SIADH? Your symptoms of SIADH result from hypotonic, hyponatremia, and are associated with hypervolemia and weight gain. The severity and rapidity of onset determine the extent of symptoms. Thirst, impaired taste, anorexia, dyspnea and exertion, fatigue, and dulled sensorium occur when the serum sodium level decreases rapidly from, let's say, 140 to 130. Peripheral edema is usually absent. Gastrointestinal symptoms include vomiting and abdominal cramps. Occur with a drop in sodium concentration from anywhere from 130 to 120. There is weight gain from water retention, even with nausea and vomiting. Even if hyponatremia develops slowly, your serum sodium levels less than 110 to 115 can cause confusion, lethargy, muscle twitching, and seizures. Severe and sometimes irreversible neurological damage may occur. Symptoms resolve with correction of hyponatremia. Any patient with hyponatremia needs to be replaced very slowly. You don't want to go more than 10 MEQ per day. Otherwise, you're going to cause neurologic damage to that patient. Evaluation and treatment. A diagnosis of SIADH includes the following manifestations: a serum hypoosmolarity and hyponatremia, urine hyperosmolarity. Osmolality of the urine is always higher than the concurrent serum osmolality. Urine sodium excretion that matches sodium intake, normal renal, adrenal, and thyroid function, absence of conditions that can alter volume status, ADH is difficult to measure in the serum. Copeptin and ADH precursor molecule may be used as a surrogate marker. Individuals with neurologic injury also may develop hyponatremia caused by cerebral salt wasting syndrome. This can be differentiated from SIADH because cerebral salt wasting is characterized by hyponatremia, hypovolemia, and weight loss. In addition, urine sodium levels are elevated. The treatment of SIADH involves the correction of the underlying causal problems and fluid restrictions, when feasible, with careful monitoring of sodium level, status, and neurologic symptoms. In severe SIADH, emergency correction of severe hyponatremia involves careful administration of hypertonic saline and, most importantly, the fluid restriction of 800 to 1000 milliliters per day. Resolution usually occurs within 3 days, with a 2 to 3 kilogram weight loss resulting from enhanced free water clearance and correction of hyponatremia and salt wasting. If hyponatremia is corrected too rapidly, a severe neurologic syndrome called central pontine myelinolysis can ensue. Demiclocycline, which causes renal tubules to develop resistance to ADH, may be used to treat resistant or chronic SIADH. Vasopressin receptor antagonists, known as VAPTANs, are effective in treating SIADH. So again, you want to correct the hyponatremia slowly. That leads us now to our next one, diabetes insipidus. Diabetes insipidus is an insufficiency of ADH, leading to polyuria, frequent urination, and polydipsia, frequent drinking. There are two forms, neurogenic or central, hypothalamic or nephrogenic, renal. Neurogenic or central diabetes insipidus is caused by insufficient secretion of ADH. It occurs when an organic lesion of the hypothalamus pituitary stalk or posterior pituitary interferes with ADH synthesis, transport, or release. Causative lesions include primary or metastatic brain tumors, hypophosphorysectomy, aneurysms, thrombosis, infections, and immunologic disorders. Neurogenic diabetes insipidus is a well-recognized complication of traumatic brain injury or pituitary surgery, in which DI can be transient or permanent. Neurogenic DI can be a complication of pregnancy. In rare cases, it also can be caused by hereditary disorders that affect ADH genes or result in structural changes in the pituitary gland. Nephrogenic DI is caused by inadequate response of renal tubules to ADH and is usually acquired or may be genetic, including genes that code for vasopressin V2 receptors and aquaporin 2 proteins. Acquired nephrogenic DI is generally related to disorders and drugs that damage the renal tubules or inhibit the generation of CAMP in the tubules. These disorders include pyelonephritis, amyloidosis, destructive uropathies, polycystic disease, and intrinsic renal disease, all of which lead to irreversible DI. Drugs that may induce a reversible form of nephrogenic DI include lithium carbonate, colchicines, amphotericin B, loop diuretics, general anesthesics, and demiclocyclines. Gestational DI is a rare form associated with pregnancy, in which the level of vasopressin degrading enzyme vasopressinase is increased. Your clinical manifestations are usually mild and do not require treatment. Eudipsogenic or primary polydipsia may be confused with DI. It occurs when excessive fluid intake lowers the plasma osmolarity to the point that it falls below the threshold for ADH secretion. This condition may be associated with psychiatric disorders, but also has been found in individuals who have low osmotic threshold for inducing thirst. It is caused by chronic ingestion of extremely large quantities of fluid that wash out the renal medullary concentration gradient, which results in a partial resistance to ADH. This condition resolves with decreased fluid ingestion. Psychogenic causes of polydipsia must be differentiated from true DI because administering an ADH analog to an individual with psychogenic DI will result in severe hypoosmolality. Our pathophysiology. So individuals with diabetes insipidus have a partial to total inability to concentrate urine. Insufficient ADH activity causes excretion of large volumes of dilute urine, leading to increased plasma osmolality. In conscious individuals, the thirst mechanism is stimulated and induces polydipsia, usually a craving for cold drinks. Dehydration develops rapidly without ongoing fluid replacement. If the individual with DI cannot conserve as much water as is lost in the urine, serum hypernatremia and hyperosmolality occurs. Concentration of other serum electrolytes generally are not affected. So what kind of clinical manifestations do we see in diabetes insipidus? Well, they include polyuria, nocturia, continuous thirst, and polydipsia. Urine output is varied but can increase from the normal output of 1 to 2 liters per day to as much as 8 to 12 liters a day and can be higher than daily fluid intake. Individuals with long-standing DI may develop a larger bladder capacity and hydronephrosis. Neurogenic DI usually has an abrupt onset, and many individuals can specifically recall the date of their onset of symptoms. Nephrogenic DI usually has a more gradual onset, and Table 22.1 compares the signs and symptoms of DI and SIADH. So I'll leave that table up for just a moment, and we'll continue on with the evaluation and treatment. DI must be distinguished from other polyuric states, including diabetes mellitus, osmotically induced diuresis, and psychogenic polydipsia. The criteria for the diagnosis of DI include polyuria, polydipsia, low urine-specific gravity, so less than 1.010, low urine osmolality, so less than 200 mosm per kilogram, hypernatremia, high serum osmolality, or more depending on the adequate water intake, and continued diuresis, despite the serum sodium level of 145 MEq or greater. The first step in the diagnosis of DI uses water deprivation with measurements of serum osmolarity and plasma ADH levels. Water deprivation is a useful test because individuals without DI respond with a rapid decrease in urine volume and an increase in urine osmolality, whereas those with DI have no decrease in urine volume and an increase in urine osmolality. In individuals with severe DI, water deprivation testing can be hazardous. If the individual loses more than 3% of the pre-test body weight, circulatory collapse and shock can ensue. Neurogenic DI can be differentiated from nephrogenic DI by measuring the response to administered desmopressin. Neurogenic DI will respond with an increased ability to concentrate the urine, whereas nephrogenic DI will not respond. The diagnosis of dipsogenic polyuria can be extremely difficult, and differentiation from nephrogenic DI is based on plasma ADH levels. Copeptin, an ADH precursor molecule, is a reliable surrogate measurement of ADH secretion and can be used for the diagnosis of dipsogenic polyuria. Treatment for nephrogenic DI is based on the extent of the ADH deficiency, on the individual's age, endocrine and cardiovascular status, and lifestyle. Some individuals require ADH replacement, but fluid replacement using oral or IV routes is usually adequate. ADH replacement therapy for symptomatic central or neurogenic diabetes insipidus include intravascular or more commonly oral or intranasal administration of the synthetic vasopressin analog, DDAVP, desmopressin. Management of nephrogenic DI require treatment of any reversible underlying disorder, discontinuation of etiologic medications, and correction of associated electrolyte disorders. Surprisingly, thiazide diuretics may improve renal tubular salt and water retention in individuals with moderate nephrogenic DI. Drugs that potentiate the action of otherwise insufficient amounts of endogenous ADH, such as chlorpropamide, carbamazepine, and clofibrate, may be used in individuals with incomplete ADH deficiency. New treatments aimed at reversing aquaporin 2 dysfunction are still being developed. Diseases of the anterior pituitary. Disorders of the anterior pituitary may involve either hypofunction or hyperfunction of the gland. A theme I think you will come across as we continue with this reading. Hypopituitarism or hypo is the absence or deficiency of one or more anterior pituitary hormones, of the complete failure of all anterior pituitary hormone functions. Hypopituitarism results from an inadequate supply of hypothalamic releasing hormones, damage to the pituitary stalk, or an inability of the gland to produce hormones. The most common cause of hypopituitarism are pituitary adenoma, pituitary surgery, or radiotherapy. Pituitary infarction results from severe shock, pituitary apoplexy, aneurysms, or sickle cell disease. Pituitary infarction may occur in women during the postpartum period because of blood loss and hypovolemic shock. Traumatic brain injury is increasingly recognized as an important cause of hypopituitarism and can have a significant impact on acute and long-term recovery in children and adults. Other causes of hypopituitarism include infection, sarcoidosis, autoimmune hepatitis, or certain drugs. Immune checkpoint inhibitors, such as ipilimumab, have been associated with hypophysitis in up to 11% of individuals treated for melanoma. A rare form of hypopituitarism is characterized by combined hormonal deficiencies and is related to mutations of the thyroid-stimulating hormone, biosynthetic pathway, or early or late transcription factors involved in early embryonic pituitary development. Your pathophysiology. The pituitary gland is highly vascular and relies heavily upon portal blood flow from the hypothalamus. Therefore, it is extremely vulnerable to ischemia and infarction. Infarction results in tissue necrosis and edema with swelling of the gland. Expansion of the pituitary within the fixed compartment of the sella turcica further impedes blood flow supply to the pituitary. Over time, fibrosis of pituitary tissue occurs and symptoms of hypopituitarism develop. Adenomas and aneurysm may compress otherwise normal secreting pituitary cells and lead to compromised hormonal output. So what clinical manifestations do we see? The signs and symptoms of hypofunction of the anterior pituitary are variable and depend on the hormones are affected. In pan-hypopituitarism, all hormones are deficient and the individual suffers from multiple complications, including cortisol deficiency from lack of ACTH, thyroid deficiency from lack of TSH, and loss of secondary sex characteristics from lack of FSH and LH. Low levels of growth hormone and insulin-like growth hormone affect children and can cause physiologic and psychologic symptoms in adults. Postpartum women cannot lactate because of a decrease or absence of prolactin. ACTH deficiency with associated loss of cortisol is a potentially life-threatening disorder. ACTH deficiency is usually encountered with generalized pituitary hypofunction. It rarely occurs as an isolated event. Within 2 weeks of the complete absence of ACTH, symptoms of cortisol insufficiency develop, including nausea, vomiting, anorexia, fatigue, and weakness. Hypoglycemia results from increased insulin sensitivity, decreased glycogen reserves, and decreased gluconeogenesis associated with hypocortisolism. ACTH deficiency also limits maximum aldosterone secretion, although the renin-angiotensin system can stimulate some aldosterone secretion. The glomerular filtration rate decreases, causing a decreased urine output. Your TSH deficiency is rarely seen in isolation, but occurs in conjunction with other pituitary hormone deficiencies. Symptoms develop 4 to 8 weeks after hypothyroidopenia occurs and includes cold intolerance, skin dryness, mild myxedema, lethargy, and a decreased metabolic rate. The symptoms are usually less severe than those associated with primary hypothyroidism. The onset of FSH and LH deficiency in women of reproductive age is associated with amenorrhea and with atrophy in the vagina, uterus, and breast. Postpubertal males, the testicles atrophy and facial hair growth is diminished. Both men and women experience a decrease in body hair and diminished libido. Growth hormone deficiency occurs in children and adults. As described previously, growth hormone deficiency may result from any of the causes of hypopituitarism. Several genetic defects have been identified in the growth hormone axis in children, including a recessive mutation in the GH gene, resulting in failure of growth hormone secretion. These include a recessive mutation in the GHRH gene, resulting in a failure of GH secretion, and mutation that cause GH insensitivity by affecting the GH receptor. IGF-1 biosynthesis, IGF-1 receptors, or defects in GH signal transduction. GH deficiency in children is manifested by growth failure and condition known as hypopituitarism dwarfism. However, not all children with short stature have growth hormone deficiency because there is a wide variation in normal growth pattern. Another feature of growth hormone deficiency in children is fasting hypoglycemia, likely attributable to impaired substrate mobilization for gluconeogenesis and enhanced insulin sensitivity. Symptoms of chronic adult GH deficiency syndrome include increased body fat, decreased muscle bulk, and lean body mass, osteoporosis, reduced sweating, dry skin, and psychologic problems, including depression, social withdrawal, fatigue, loss of motivation, and diminished feeling of well-being. Without adequate GH replacement, increased mortality can occur as a result of myocardial infarction and stroke association with dyslipidemias and atherosclerosis. So what's our evaluation and treatment? The diagnostic evaluation of suspected pituitary disease is often challenging and must be carefully interpreted together with the individual's signs and symptoms. Simultaneous measurements of the tropic hormones from the pituitary and target endocrine glands are crucial, and in some cases, dynamic testing of the various axes is indicated, particularly growth hormone and ACTH. Radiographic assessment of the pituitary, an MRI or CT scan, may demonstrate enlargement of the pituitary abnormal areas of enhancement suggestive of adenoma, deviation of the pituitary stalk, or evidence of locally aggressive tumor. Management of hypopituitarism is individualized and requires correction of the underlying disorder as quickly as possible. Replacement of target gland hormones that are deficient because of lack of tropic anterior pituitary hormones is essential. In cases of circulatory collapse, immediate therapy with glucocorticoids and IV fluids is critical. Treatment adaptations are made during pregnancy and in transition from childhood to adulthood. Treatment of adult growth hormone deficiency improves quality of life, metabolism, body composition, and physical performance in some individuals. So let's go the opposite way. Instead of hypo, let's go into the hyperpituitarism, your primary adenoma. Your pituitary adenomas are usually benign, slow-growing tumors that arise from cell of the anterior pituitary. The cause of pituitary adenomas is not known and most occur sporadically. Altered gene expression is commonly detected, and familial pituitary adenomas occur as part of syndromes affecting other organs, such as multiple endocrine neoplasia type 1. Microadenomas are found only on post-mortem examination or incidentally discovered on MRI exams. The majority of pituitary microadenomas are hormonally silent and do not pose significant hazards to the individual. Macroadenomas and giant adenomas are associated with morbidity and mortality attributable to alterations in hormone secretion or to invasion or impingement of structures surrounding the pituitary. The pathogenesis of pituitary adenomas include hypothalamic and intrapituitary factors, including altered expression of pituitary cell cycle genes, activation of pituitary selective oncoproteins, or loss of pituitary suppressor factor. Several associated gene mutations have been identified, including isolated growth hormone deficiency and those associated with multiple endocrine neoplasia syndromes. Primary pituitary carcinomas are rare, representing only about 2% of all pituitary tumors. So what is the pathophysiology behind it? Local expansion of pituitary adenomas may impinge on the optic chiasm and cause various visual disturbances, depending on the area of the optic nerve that is being compressed. If the tumor is locally aggressive, invasion of the cavernous sinuses may occur, resulting in compression of the oculomotor, trochlear, abducens, and trigeminal nerve, with attending symptoms. Extension to the hypothalamus disturbs control of wakefulness, thirst, appetite, and temperature. Benign, slow-growing adenomas can transform to aggressive adenomas or carcinomas. Hormonal effects of adenomas include hypersecretion from the adenoma itself and hyposecretion from surrounding pituitary cells. The, the adenomatous tissue secretes the hormone of the cell type from which it arose, with regard to physiologic need and without benefit of regulatory feedback mechanism. Because of the pressure exerted by the tumor in the unexpandable bony cella tertia, hyposecretion from the cells is most sensitive to common pressure. So again, it's your growth hormone, your FSH, and LH secreting cells. So what kind of clinical manifestations would you see? The clinical manifestations of a pituitary adenoma are related to tumor growth and hormone hypersecretion or hyposecretion. Increased tumor size causes headaches and fatigue, neck pain, stiffness, and possible seizures. Visual changes include visual field impairments and temporarily blindness. If the tumor infiltrates other cranial nerves, neurological function could be affected. Pituitary adenomas are most often associated with an increased secretion of growth hormone and prolactin. Gonadotropic hyposecretion results in menstrual irregularities in women, a decreased libido, and receding secondary sex characteristics in both men and women. If the tumor exerts sufficient pressure, thyroid and adrenal hypofunction may occur because of lack of TSH and ACTH, resulting in symptoms of hypothyroidism and hypocortisolism, respectively. Evaluation and treatment. Diagnosing of a pituitary adenoma involves physical and lab evaluations, including pertinent hormone assays and radiographic exams, your MRI preferred, or contrast CT. The goal of treatment is to protect the individual from the sense of tumor growth and manage hormone hypersecretion or hyposecretion while minimizing damage to the appropriately secreting portion of the pituitary. Depending on the tumor size and type, individuals may be treated by administration of specific medications to suppress tumor growth, transsphenoidal tumor resection, or radiation therapy, including stereotactic treatments. Observation and close follow-up are commonly employed for individuals who have no evidence of hormonal alterations and no suggestion of anatomic aggressiveness. Chemotherapy with temozolomide is considered for those individuals who are still uncontrolled. So, what happens if you have the hypersecretion of a growth hormone? Well, we end up with acromegaly. Acromegaly results from the continuous exposure to high levels of growth hormone and IGF-1. It almost always is caused by a growth hormone secreting pituitary adenoma and rarely results from an ectopic production of your GHRH. Acromegaly usually occurs in adults anywhere in the 40s to 59-year-old age group, although it is often present for years before diagnosis because of the insidious nature of the disease. Consequently, there are systemic complications at diagnosis, leading to increased mortality and a premature death. Deaths from acromegaly are caused by heart disease, secondary to hypertension and coronary artery disease, strokes, diabetes, or other malignancies, your colon and lung cancers. So the pathophysiology behind acromegaly. Your growth hormone secreting adenoma, the usual growth hormone baseline secretion pattern, and sleep regulated growth hormone peaks are lost, and an unpredictable secretory pattern ensues. However, growth hormone levels in acromegalics are never completely suppressed. Only slight elevations of growth hormone and IGF-1 levels can stimulate growth. In children and adolescents, whose epiphyseal plates have not yet closed, the effect of increased growth hormone levels causes that excessive skeletal growth, which is why you have that growth spurt, with some individuals becoming 8 or 9 feet tall, termed giantism. In the adult, epiphyseal closure has occurred, and increased amounts of growth hormone and IGF-1 cause connective tissue proliferation and increased cytoplasmic matrix, as well as bony proliferation that result in the characteristic appearance of acromegaly, which I think we're about to take a look at. So here you have a giantism, and in contrast, a dwarf. So here you have the acromegaly in a male, where you see the facial feature change. And here you again see a picture of acromegaly. You have a transfrontal scar or frontal blossom. So growth hormone also has significant effects on glucose, lipid, and protein metabolism. Surprise, surprise. Hyperglycemia results from inhibition of the peripheral glucose uptake and increased hepatic glucose production, followed by compensatory hyperinsulinism, adipose tissue inflammation, and impaired adipogenesis contribute to insulin resistance. Diabetes mellitus occurs when the pancreas cannot secrete enough insulin to offset the effects of growth hormone. Excessive levels of growth hormone and IGF-1 also affect the cardiovascular system. Although the associated pathophysiology is not clearly understood, hypertension and left heart failure are seen in one-third to one-half of individuals with acromegaly. Cardiomyopathy associated with progressive and unrestrained myocardial growth is a significant factor. Valvular heart disease and arrhythmias can occur. Your growth hormone also acts on the renal tubules to increase phosphate reabsorption, leading to mild hyperphosphatemia. Because the adenoma increasingly becomes a space-occupying lesion, hypopituitarism may occur because of compression of surrounding hormone-secreting cells. So what clinical manifestations do we see? With connective tissue proliferation, individuals with acromegaly have enlarged tongues, interstitial edema, enlarged and overactive sebaceous and sweat glands, and coarse skin and body hair. Bony proliferation involves large joint arthropathy, periosteal vertebral growth, and enlargement of the bones of the face, hands, and feet. As a result, decreased joint range of motion, kyphosis, and lower jaw and forehead protrusion are common. Increased IGF-1 levels stimulate cartilaginous growth and cause ribs to elongate at the bone-cartilage junction, leading to a barrel chest appearance, and increased proliferation of cartilage in the spine and joints, which causes backache and arthralgias. With continued bony and soft tissue overgrowth, entrapment of nerves may occur, leading to peripheral nerve damage as manifested by weakness, muscular atrophy, foot drop, and sensory changes in the hands. Your carpal tunnel syndrome. Your sleep-disordered breathing is common and may exacerbate cardiovascular dysfunction. Symptoms of diabetes mellitus, such as polyuria and polydipsia, may occur because of decreased insulin sensitivity in an individual who cannot mount adequate compensatory hyperinsulinemia. Acromegaly-associated hypertension is usually asymptomatic until heart failure symptoms develop. Increased tumor size results in central nervous system symptoms of headache, seizure activity, visual field disturbances, and papilledema. If compression of hypopituitarism occurs, gonadotropin secretion may be affected, causing amenorrhea in women and sexual dysfunction in men. Hyperprolactinemia can occur in 30 to 40% of individuals with acromegaly. Recent reports have documented mutation in the aryl hydrocarbon interacting protein gene, or AIP, in sporadic cases of familial acromegaly. Polymorphism in the somatostatin receptor type 5 gene, and a GTP binding protein receptor mutation. So, what kind of evaluation and treatment do we have if you have acromegaly? Well, your diagnosis is confirmed by the appearance of clinical features of disease, visual field testing, MRI scans, and elevated levels of IGF-1. Your growth hormone level is typically elevated and not suppressed with oral glucose tolerance testing. The goals of treatment are to normalize growth hormone and IGF-1 serum levels to age range, restoring normal pituitary function, and relieving or preventing complications related to the tumor's expansion. The treatment of choice for acromegaly is transsphenoidal surgery for the removal of the growth hormone secreting adenoma. Treatment by stereotactic radiation therapy may be effective when rapid control of growth hormone level is not essential. When the individual is not a good surgical candidate or when hyperfunction persists after subtotal resection, somatostatin analogs such as octreotide, octreotide acetate, and lanreotide normalize IGF-1 levels and lower growth hormone levels. Your pegvisomant can be used to supplement somatostatin analogs and is an effective drug that induces tissue insensitivity to growth hormone by blocking the growth hormone receptor. Dopaminergic agonists such as cabergoline also may be helpful, especially if the tumor also secretes prolactin. Diagnostic and therapeutic clinical practice guidelines are available to support management during pregnancy and long-term management. Your cardiovascular, metabolic, and symptoms of tumor compression often improve with treatment. Skeletal abnormalities are irreversible. Your hypersecretion of prolactin, your prolactinoma. Pituitary tumors that secrete prolactin, or prolactinomas, are the most common of the hormonal active pituitary adenomas. Other conditions or medications can elevate prolactin level in absence of pituitary pathologic condition. For example, renal failure, polycystic ovarian disease, breast stimulation, or even the stress of venopuncture can increase prolactin levels. Prolactin under tonic inhibitory hypothalamic control through the secretion of dopamine. Thus, medications that block effects of dopamine can increase prolactin production and stimulate proliferation of prolactin secreting cells. These include antipsychotics, your risperidone, chlorpromazine, metoclopramide, tricyclic antidepressants, and methyldopa. Any process that interferes with the delivery of dopamine from the hypothalamus to the lactotropes also result in hyperprolactinemia because TRH stimulating prolactin secretion, in addition to enhancing TSH release, prolactin concentration may be elevated in individuals with primary hypothyroidism. So your pathophysiology. The hallmark of prolactinoma is sustained increases in serum prolactin concentration. These tumors can be identified as microprolactinomas or macroprolactinomas. Microprolactinomas are usually encapsulated and non-invasive, whereas your macroprolactinomas commonly expand into the optic chiasm, invade local structures, and are more difficult to treat. Because the adenoma can become an increasingly space-occupying lesion, hypopituitarism may occur because of compression of surrounding hormone-secreting cells. Central nervous system symptoms may develop because of growth and pressure of adenoma within the cella cercica. Your clinical manifestations. The, phys- the physiology action of prolactin include breast development during pregnancy, postpartum milk production, and suppression of ovarian function in nursing women. Pathologic elevation of prolactin level inhibit the pulsatile secretion of gonadotropin-releasing hormone, alters the pattern of releasing of luteinizing hormone and follicle-stimulating hormone, and suppressing gonadal steroidogenesis, thereby resulting in hypogonadotropic hypogonadism in both sexes. This causes amenorrhea, infertility, non-puerperal milk production, and hirsutism in women. If not detected until after many years, estrogen deficiency may result in osteopenia or osteoporosis. Your hyperprolactinemia in men causes erectile dysfunction, infertility, and osteopenia. Symptoms related to the increasing size of adenoma include headache or visual impairment. So our evaluation and treatment, therefore, the diagnostic evaluation of hyperprolactinemia include a careful history to exclude medications or other diseases that may cause elevations in prolactin level. Symptoms of hypothyroidism should be elicited, and screening with a serum TSH measurement is mandatory. MRI scans of a pituitary is indicated to determine the size and location of the adenoma. If prolactin concentration is less than 50 ng per ml, a careful search for a non-pituitary cause should be pursued. The goal of treatment are to restore normal gonadal function and fertility to reduce tumor size. Your dopaminergic agonists are the treatment of choice for prolactinomas, and their use is often associated with both a rapid reduction in the size of the tumor and the reversal of the gonadal effects of hyperprolactinemia. Restoration of fertility in previously anovulatory women is common. In individuals resistant to or intolerant to these medications, transsphenoidal surgery and radiotherapy are options. New chemotherapeutic and targeted molecular therapies are being explored. That leads us to our alterations of thyroid function. Disorders of thyroid function develop as a result of primary dysfunction or disease of the thyroid gland, or secondarily as a result of pituitary or hypothalamic alterations. Primary thyroid disorders result in alterations in thyroid hormone level with secondary feedback effects on the pituitary TSH level. For example, when there are primary elevations in TH level, TSH level will secondarily decrease because of a negative feedback. When TH level is decreased because of a condition affecting the thyroid gland, TSH levels will be elevated. Your thyroid disease also can present with no or minimal symptoms, but with abnormal laboratory values. This is known as subclinical thyroid disease. Central, your secondary thyroid disorders, are related to disorders of pituitary gland TSH production. When there is excessive TSH production, TH level is elevated secondarily to the primary elevation of TSH level. The reverse is true with inadequate TSH production. Exposure to iodinated contrast media has been shown to be associated with development of both hyperthyroidism and hypothyroidism. Thyrotoxicosis, your hyperthyroidism. Thyrotoxicosis is a condition that results from any cause of increased amounts of TH levels. Hyperthyroidism is a form of thyrotoxicosis. in which excess amounts of TH are secreted from the thyroid gland. The terms thyrotoxicosis and hyperthyroidism are often used interchangeably. The prevalence of hyperthyroidism is estimated to be 0.7 to 2.1 in the US, of which 0.7 is subclinical and is more prevalent in women and in iodine-deficient geographic areas. Thyroid hormones are regulated by a negative feedback loop involving the hypothalamus, pituitary gland, and thyroid gland. Common diseases that cause primary hyperthyroidism include Graves' disease, toxic multinodular goiter, a solitary toxic adenoma, and very rarely a follicular thyroid carcinoma. Your central hyperthyroidism is less common and is caused by a TSH secreting pituitary adenoma. Thyrotoxicosis is not associated with hyperthyroidism, includes ectopic thyroid tissue or ingestion of excessive TH, and low thyroid radioactive iodine uptake. Each condition is associated with a specific pathophysiologic manifestation and treatment. However, all forms of thyrotoxicosis share some common characteristics. So here's a picture of Graves' disease, your TSH receptor antibodies. So what kind of clinical manifestations do we see? The clinical features of thyrotoxicosis are attributable to the metabolic effect of increased circulating levels of TH. This usually results in an increased metabolic rate with heat intolerance and increased tissue sensitivity to stimulation by the sympathetic division of the autonomic nervous system. The major manifestations are summarized in Table 22.2. The enlargement of the thyroid gland or goiter is common in hyperthyroid conditions caused by stimulation of TSH receptor. So here you see the differentiation between hypo and hyperfunction. And I'm going to leave this picture up for just a moment. And then here's the table 22.2. So your systemic manifestations of hyperthyroidism has effects on the endocrine, reproductive, gastrointestinal, integumentary, sensory, cardiovascular, nervous, pulmonary systems. So what's our evaluation and treatment? The elevated serum of tetraiodothyronine or thyroxine T4 and its T3 counterpart, the triiodothyronine, levels and decreased serum TSH levels are diagnostic for primary hyperthyroidism. By contrast, central, your secondary hyperthyroidism, caused by TSH secreting pituitary tumor, is characterized by a normal to increased TSH levels, despite elevated thyroid hormone concentration. Radioactive iodine is used to test for increased uptake in primary hyperthyroidism. Treatment is directed at controlling excessive TH production, secretion, or action, and includes the antithyroid drug therapy, your methimazole, or your propylthiouracil. Radioactive iodine therapy, absorbed only by the thyroid tissue, causing death of the cells, and surgery. Guidelines for treatment of hyperthyroidism and thyrotoxicosis have been published. Treatment of subclinical hyperthyroidism is based on the lower levels of TSH with free T4 and T3 concentrations. within the reference range and clinical symptoms. A major complication of all forms of treatment for hyperthyroidism is hypothyroidism. So, we have our hyperthyroid conditions. It mentioned Graves' disease. Graves' disease is the underlying cause of about 50 to 80% of cases of hyperthyroidism and has a prevalence of about 3% in women and 0.5% in men in the US. Although the cause of Graves' disease is not known, genetic factors interacting with environmental triggers play an important role in the pathogenesis. Graves' disease is classified as an autoimmune disease and results from a form of a type 2 hypersensitivity in which there is infiltration of lymphocytes and stimulation of the thyroid by autoantibodies directed against the TSH receptor. These autoantibodies, called thyroid-stimulating immunoglobulins, TSIs, also called thyroid-stimulating antibodies, or thyroid receptor antibodies, override normal negative feedback mechanisms. The TSI stimulation of TSH receptors in the glands result in hyperplasia of the gland, which creates that goiter, and increased synthesis of TH, especially of T3. Increased levels of TH affect every physiologic system and result in classic signs and symptoms of hyperthyroidism. TSH production by the pituitary is inhibited through the usual negative feedback loop. TSIs also contribute to two major distinguishing clinical manifestations of Graves' disease: ophthalmology and dermopathy, your pretibial myxedema and acropathy. Two categories of ophthalmopathy associated with Graves' disease are the functional abnormalities resulting from hyperactivity of the sympathetic division of the autonomic nervous system, lag of the globe on upward gaze or a lag of the upper lid on downward gaze, and infiltrative changes involving the orbital content with enlargement of the ocular muscles. The infiltrative changes possibly result from TSH receptor autoantibodies reacting with receptors on orbital fibroblasts. These changes affect more than half of the individuals with Graves' disease. Increased secretion of hyaluronic acid, adipogenesis, inflammation, and edema of the orbital contents result in exophthalmos, the protrusion of the eyeball, periorbital edema, and extraocular muscle weakness, leading to strabismus and diplopia. The individual may experience irritation, pain, lacrimation, photophobia, blurred vision, decreased visual acuity, papilledema, visual field impairment, exposure keratosis, and corneal ulceration. Smoking exacerbates the disease. So here you see the picture of the enlargement of the eyes, for instance. A small number of individuals with Graves' disease and very high levels of TSI experience pretibial myxedema or Graves' dermopathy. Again, you see that in the legs here in the picture, characterized by subcutaneous swelling on the anterior portions of the legs and by indurated or erythematous skin. Graves' dermopathy is associated with a thyrotropin receptor antigen on fibroblasts and recruited T lymphocytes that stimulate excess amounts of hyaluronic acid production in the dermis and subcutaneous tissues. The manifestations occasionally appear on the hands, giving the appearance of clubbing of the finger, your thyroid acropathy. Your therapy for Graves' disease includes antithyroid drugs, radioactive iodine ablation, or surgery. Smoke cessation is necessary. Unfortunately, current treatment for Graves' disease does not reverse the infiltrative ophthalmopathy or the pretibial myxedema. Surgical orbital decompression and glucocorticoids can help many individuals with progressive ophthalmopathy. Immunosuppressive drugs, such as rituximab, are being evaluated. Skin lesions rarely require treatment, but if they are symptomatic, they may respond to topical glucocorticoids. Hyperthyroidism resulting from a nodular thyroid disease. The thyroid gland normally enlarges in response to an increased secretion of TSH that occurs in puberty, pregnancy, or iodine deficiency, and from immunologic, viral, or genetic disorders. The increased number of follicles is a compensatory mechanism in response to increased TSH levels. When the condition requiring increased TH resolves, TSH secretion normally subsides, and the thyroid gland returns to its original size. Irreversible changes may occur in some follicular cells. Thus, these cells function autonomously and produce excessive amounts of TH. On the other hand, some follicular cells may cease to function. The balance between the amount of TH produced by hyperfunctioning nodules and that produced by the remainder of the gland determines whether an individual becomes euthyroid or hyperthyroid. Non-toxic nodular goiter is more common in iodine-deficient regions and may require decompression when associated with airway, esophageal, or venous obstruction. Toxic multinodular goiter occurs when there are several hyperfunctioning nodules, leading to hyperthyroidism. If only one nodule becomes hyperfunctioning, it is termed solitary toxic adenoma. Unlike Graves' disease, there is an absence of the autoimmune stimulus. The classic manifestation of hyperthyroidism usually develops slowly, and exophthalmos and pretibial myxedema do not occur. Nodules may be palpable on physical exam, and there is an increased uptake of radioactive iodine. The incidence of malignancy in toxic multinodular goiter is more likely in single nodules, so most individuals should undergo a fine needle aspiration biopsy of suspicious nodules before treatment. Treatment consists of a combination of radioactive iodine, surgery, or antithyroid drugs. That leads us to a thyrotoxic crisis, also known as your thyroid storm, which is a rare but dangerous worsening of the thyrotoxic state, in which death can occur within 48 hours without treatment. The condition may develop spontaneously, but it usually occurs in individuals who have undiagnosed or partially treated severe hyperthyroidism and who are subjected to excessive stress from other causes. These causes may include infection, pulmonary or cardiovascular disorders, traumas, burns, seizures, surgeries, obstetric complications, emotional distress, or dialysis. The symptoms of thyroid crisis are caused by the sudden release and increased action of your thyroxine, that T4 and T3 triiodothyronine, exceeding metabolic demand. The systemic symptoms of a thyrotoxic crisis include hyperthermia, tachycardia, especially atrial tachydysrhythmias, high output heart rate failure, agitation or delirium, nausea, vomiting, diarrhea, contributing to fluid volume depletion. Treatment includes the use of drugs that block TH synthesis, your propylthiouracil or methimazole, the use of beta blockers for the control of cardiovascular symptoms, administration of corticosteroids or iodine, saturated solution of potassium iodide, and supportive care. Plasma exchange or a thyroidectomy may be used when medical treatment fails. So that was all the hypers. That leads us to the hypos, the low section of hypothyroidism. Hypothyroidism results from deficient production of TH by the thyroid gland. Hypothyroidism is the most common disorder of thyroid function. It affects between 0.1 and 2% of US populations, and is more common in women and the elderly. It may be primary or secondary. Your primary hypothyroidism accounts for 99% of all cases. Your central hypothyroidism, which is much less common, is related to the either pituitary or hypothalamic failure. So the pathophysiology. The loss of thyroid function is primarily hypothyroidism, leads to a decreased production of TH and an increased secretion of TSH and TRH. The most common causes in adults include autoimmune thyroiditis, your Hashimoto disease, iatrogenic loss of thyroid tissue after surgical or radioactive treatment for hyperthyroidism, head and neck radiation therapy, medications, and endemic iodine deficiency. Infants and children may present with hypothyroidism because of congenital defects in the pituitary or thyroid gland. Your central hypothyroidism is caused by the pituitary's failure to synthesize adequate amounts of TSH or a lack of TRH. Pituitary tumors that compress surrounding pituitary cells or, or the consequences of their treatment are the most common causes of secondary hypothyroidism. Other causes include traumatic brain injury, subarachnoid hemorrhage, or pituitary infarction. Hypothalamus dysfunction results in low levels of TRH, TSH, and TH. Subclinical hypothyroidism is mild thyroid failure and is estimated to occur in 4 to 8% of U.S. adults. It is defined as an elevation of TSH level with normal levels of circulating TH. So here we're taking a look at mechanisms of primary and central hypothyroidism. So I'll leave that up as I keep going. Your clinical manifestations. Hypothyroidism generally affects all body systems and occurs insidiously over months or years. The extent of these symptoms is closely related to the degree of TH deficiency. The decrease in TH level lowers energy metabolism and heat production. The individual develops a low basal metabolic rate, cold intolerance, lethargy, tiredness, and slightly lower basal body temperatures and may have diastolic hypertension. Many organ systems are affected. The decrease in level of TH can lead to excessive TSH production, which stimulate the thyroid tissue and causes goiter. So again, our systematic manifestation of hypothyroidism will have neurologic, endocrine, reproductive, hematologic, cardiovascular, pulmonary, renal, gastrointestinal, musculoskeletal, and tegumentary aspects. So I'm letting it slide on over. You can always pause the video to read specifics. The characteristic sign of severe or long-standing hypothyroidism is myxedema, which results from altered composition of the dermis and other tissues. The connective fibers are separated by an increased amount of protein and mucopolysaccharides. This protein mucopolysaccharide complex binds water, producing non-pitting boggy edema, especially around the eyes, hands, and feet, and in the supraclavicular fossa. The tongue and laryngeal and pharyngeal mucous membrane thicken, produce thick, slurred speech, and hoarseness. Your myxedema coma, a medical emergency, is diminished levels of consciousness associated with severe hypothyroidism. Most individuals are not unconscious. Precipitating events include infection, discontinuation of thyroid supplements, overuse of narcotics or sedatives, or a consequence of an acute illness in individuals who have hypothyroidism. Older individuals with comorbid conditions, such as pulmonary or urinary tract infection, congestive heart failure, or a cerebrovascular accident, and with moderate or untreated hypothyroidism are particularly at risk. Signs and symptoms include hypothermia without shivering, hypoventilation, hypotension, hypoglycemia, lactic acidosis, and coma. Symptoms of hypothyroidism in older adults should not be attributed to normal aging changes. So our evaluation and treatment, therefore, the diagnosis of primary hypothyroidism is made by documentation of the clinical symptoms of hypothyroidism and by measurements of increased levels of TSH and decreased levels of TH, both T3 and T4. When hypothyroidism is caused by pituitary deficiencies, your serum TSH levels are decreased or are inappropriately normal in the face of low level of TH. Your hormone replacement therapy with the hormone levothyroxine, or Synthroid, is the treatment of choice for hypothyroidism. Treatment of subclinical hypothyroidism is related to elevated levels of TSH and clinical symptoms. The restoration of normal TH levels should be timed appropriately. A regimen of hormonal therapy depends on the individual's age, the duration and severity of hypothyroidism, and the presence of other disorders, particularly cardiovascular disorders. Pregnant women need to be evaluated for thyroid function. Treatment of myxedema coma with thyroid hormone combined with circulatory and ventilatory support and management of hyponatremia and hypothermia is usually effective. Mortality can be as high as 25% though, however. So other hypothyroid conditions. Your primary hypothyroidism. Primary hypothyroidism has several causes. Iodine deficiency, your endemic goiter, is the most common cause worldwide, but is relatively rare in the US because of the use of iodized tablet salt in fortified foods. The most common cause of hypothyroidism in the US is an autoimmune thyroiditis, Hashimoto's disease, chronic lymphocytic thyroiditis, which results in gradual inflammatory destruction of thyroid tissue. Hashimoto disease occurs in genetically predisposed individuals, and epigenetic mechanisms are probably involved. Variants in major histocompatibility complex antigens have been associated with autoimmune thyroiditis that are different from those found in Graves' disease. Infiltration of thyroid autoantibodies, your antithyroid peroxidase, and antithyroglobulin antibodies, autoreactive T lymphocytes, natural killer cells, and inflammatory cytokines, and induction of apoptosis are involved in tissue destruction, seen in Hashimoto thyroiditis. Goiter formation is commonly observed. Hashimoto disease is commonly associated with other autoimmune conditions. Autoimmune thyroiditis is diagnosed by the presence of thyroperoxidase and thyroglobulin antibodies. Treatment is symptomatic and requires thyroid hormone replacement. Your subacute thyroiditis or subacute granulomatous thyroiditis or Quervian thyroiditis is an uncommon non-bacterial inflammation of the thyroid, often preceded by a viral infection. It is accompanied by fever, tenderness, and enlargement of the thyroid. The inflammatory process initially results in elevated levels of TH, caused by release of stored thyroglobulin, which is then followed by transient hypothyroidism before the gland recovers normally. Thyroid antibodies are not present in the blood. Symptoms may last 2 to 4 months, and nonsteroidal anti-inflammatory drugs or corticosteroids usually resolve them. Painless or silent thyroiditis has a course similar to that of subacute thyroiditis, but is pathologically identical to Hashimoto's disease. Iatrogenic hypothyroidism results from radioiodine thyroid ablation, thyroidectomy, and medication, lithium and amiodarone. Postpartum thyroiditis is pathologically related to Hashimoto disease and generally occurs within 6 to 12 months of delivery with a course similar to that of painless thyroiditis. A hyperthyroid phase with a low thyroid radioiodine uptake precedes the hypothyroid phase in typical cases of subacute painless or postpartum thyroiditis. Spontaneous recovery occurs 95% of the time, or 95% of these conditions. Congenital hypothyroidism. Congenital hypothyroidism in infants occurs when thyroid tissue is absent or with hereditary defects in thyroid hormone synthesis. Thyroid dysgenesis occurs more often in female infants with permanent abnormalities in 1 of every 4,000 live births. Congenital hypothyroidism in children is caused by defects in thyroid-stimulating hormone synthesis. Because TH is essential for embryonic growth, particularly of brain tissue, the infant will be cognitively disabled if there is no thyroxine during fetal life. The fetus is dependent on maternal thyroxine for the first 20 weeks of gestation. Hypothyroidism may not be evident at birth, since there is transplacental passage of some maternal thyroid hormone. Symptoms may include high birth weight, hypothermia, delay in passing meconium, and neonatal jaundice. Cord blood can be examined in the first days of life for measurement of T4 and TSH levels. The probability of normal growth and intellectual function is high if treatment with synthroid or levothyroxine is started before the child is 3 or 4 months old. The earlier thyroid hormone replacement therapy is initiated, the better the child's outcome. Without early screening, hypothyroidism may not be evident until after 4 months of age. Symptoms include difficulty eating, a horsey cry, and protruding tongue, caused by myxedema of oral tissue and vocal cords, hypotonic muscles of the abdomen with constipation, abdominal protrusion, and umbilical herniation. Subnormal temperature, lethargy, excessive sleeping, slow pulse, and cold. Mottled skin. Skeletal growth is shunted or stunted because of the impaired protein synthesis, poor absorption of nutrients, and lack of bone mineralization. The individual will be dwarfed with short limbs if not treated. Dentition is often delayed. Cognitive disability varies with the severity of hypothyroidism and the length of delay before initiation of treatment. Treatment is required for life. And that was an adult cretin in the picture. Thyroid carcinoma. Your thyroid carcinoma accounts for 56,870 estimated new cases and 2010 estimated cancer deaths in 2017 in the US. Wow, okay. I was trying to read that and it just sounded bad. So let me rephrase that. Your thyroid carcinoma accounts for 56,870 cases and 2010 estimated cancer deaths in 2017 in the US. There we go. Although it is the most common endocrine malignancy, it constitutes less than 4% of all neoplasm. Exposure to ionizing radiation, especially during childhood, is the most consistent causal factor. Papillary and follicular thyroid carcinomas are the most frequent, 80 to 85%, and are usually well differentiated. Medullary occurs in C cells and secretes calcitonin and carcinoembryonic antigens, and anaplastic thyroid carcinomas are less common. Most individuals with thyroid carcinoma have normal T3 and T4 levels and are therefore euthyroid. Thyroid cancer typically is discovered as a small thyroid nodule or as a metastatic tumor, most commonly occurring in the regional lymph nodes, lung, brain, or bone. Changes in voice and swallowing and difficulty in breathing are related to the tumor growth impinging on the trachea or esophagus. Ultrasound characteristics may be suggestive of malignancy, but are neither sensitive nor specific. The diagnosis of a thyroid carcinoma is generally made by a fine needle aspiration of the thyroid nodule. Treatment for well-differentiated thyroid carcinomas remains somewhat controversial, mainly because of the protracted nature and relative low mortality. Regardless of the method of treatment, treatment of well-differentiated tumors includes surgical dissection, postoperative radioactive iodine therapy to treat any microscopic residual tumor, and suppression of TSH with Synthroid to replace TH and suppress TSH on any tumor cell. Anaplastic thyroid carcinoma carries a grave prognosis, and palliation with surgical debulking, external beam radiotherapy, and a chemotherapy may be offered. New insights into the molecular pathogenesis of thyroid carcinoma are leading to new therapies, including immunotherapy and oncolytic virotherapy. So that leads us to alterations of our parathyroid function. Your hyperparathyroidism. Hyperparathyroidism is characterized by greater than normal secretion of the parathyroid hormone and hypercalcemia. Hyperparathyroidism is classified as primary, secondary, or tertiary. The pathophysiology of primary hyperparathyroidism is characterized by inappropriate excess secretion of PTH by one or more of the parathyroid glands. It is one of the most common endocrine disorders. About 80 to 85% of cases are caused by the parathyroid adenomas. Another 10 to 15% result from a parathyroid hyperplasia, and roughly 1% of cases are caused by parathyroid carcinomas. In addition, primary parathyroidism, hyperparathyroidism rather, may be caused by a variety of genetic causes, especially the genes that cause multiple endocrine neoplasia, your MEN1 and MEN2 alpha. In primary hyperparathyroidism, PTH secretion is increased and is not under the usual feedback control mechanism. The calcium level in the blood increases because of increased bone resorption and gastrointestinal absorption of calcium, but fails to inhibit PTH secretion at a normal level of calcium because the feedback threshold for calcium is set at a higher level in the abnormal parathyroid tissue. Hypercalcemia and hypophosphatemia are the hallmarks of primary hyperparathyroidism. The effects of excessive PTH secretion and primary hyperparathyroidism on various organ systems are summarized here on this table. So again, we have different locations where they work differently. I'll leave this up for a little bit, but again, you can always pause the video and read through this. Your normal calcemic hyperparathyroidism is a phenotype of primary hyperparathyroidism characterized by increased levels of PTH. Normal total and ionized serum calcium concentrations, normal activated vitamin D levels, and no underlying etiology. Increased PTH screenings for osteoporosis has led to the development of this diagnosis. There may be tissue resistance to PTH or elevated levels of PTH. may represent an early phase of primary hyperparathyroidism, as ultimately there is development of hypercalcemia. Your secondary hyperparathyroidism is a compensatory response of parathyroid glands to chronic hypocalcemia, which is a common complication of chronic kidney disease or vitamin D deficiency. Secretion of PTH is elevated, but PTH cannot achieve normal calcium levels because of insufficient levels of activated vitamin D. Other causes of secondary hyperparathyroidism include chronic vitamin D or calcium deficiency, decreased intestinal absorption of vitamin D or calcium, and ingestion of drugs such as phenytoin, phenobarbital, and laxatives, which either accelerate the metabolism of vitamin D or decrease the intestinal absorption of calcium. Your tertiary hyperparathyroidism can develop after any long-standing period of hypocalcemia, such as those seen with chronic dialysis or gastrointestinal malabsorption. In these individuals, prolonged hypocalcemia causes parathyroid chief cell hyperplasia and excess PTH production. It is most commonly seen after renal transplantation. After correction of the renal failure by renal transplant, the hypertrophied parathyroid tissue continues to oversecrete PTH. Consequently, serum calcium levels are normal or even elevated in these individuals because the hyperplastic glands function autonomously despite withdrawal of calcium and calcitriol. New drugs are being used to inhibit the synthesis of PTH. The surgical removal of one or more of the parathyroid glands is completed when there is no response to medical treatment. Familial hypocalciuric hypercalcemia is a benign autosomal dominant condition that can mimic hyperparathyroidism and is characterized by a high serum calcium level, low serum phosphate level, and low urine calcium excretion. It is caused by a mutation in the calcium sensing receptor in the parathyroid gland. It can be differentiated from primary hyperparathyroidism by the measurement of the 24-hour urine calcium excretion, which is very low in familial hypocalciuric hypercalcemia. So, clinical manifestations: hypercalcemia and hypophosphatemia, again, are those hallmarks of primary hyperparathyroidism and may be discovered incidentally. Your hypercalcemia and hypophosphatemia may be asymptomatic, or affected individuals may present with symptoms related to muscular, nervous, GI symptoms including fatigue, headache, depression, anorexia, nausea, vomiting, excessive osteoclastic and osteocytic activity resulting in bone resorption may cause pathologic fractures, kyphosis of the dorsal spine, and compression fractures of the vertebral bodies. The increased renal filtration load of calcium leads to hypercalciuria. Hypercalcemia also affects proximal renal tubular function, causing metabolic acidosis and production of an abnormally alkaline urine. Your PTH hypersecretion enhances renal phosphate excretion and results in hypophosphatemia and hyperphosphaturia. In combination of these three variables, hypercalciuria, alkaline urine, and hyperphosphaturia predisposes the individual to the formation of calcium stones, particularly in the renal pelvis or in the renal collecting ducts. These may be associated with infections. Your hypercalcemia also impairs the concentrating ability of the renal tubule by decreasing its response to ADH. Chronic hypercalcemia of the hyperparathyroidism is associated with a mild insulin resistance, necessitating increased insulin secretion to maintain a normal glucose level. Your secondary hyperparathyroidism caused by renal disease presents clinically not only with bone resorption, but also with the symptoms of hypocalcemia and hyperphosphatemia. Hypocalcemia can cause many significant clinical symptoms. Hyperphosphatemia can cause deleterious effects on the cardiovascular system. So, what would be our elevation and treatment? The concurrent findings of increased ionized calcium concentration in the face of elevated PTH concentrations are suggestive of primary hyperparathyroidism. PTH levels also may be inappropriately within the normal range because hypercalcemia should completely suppress PTH production. Observation of asymptomatic individuals with mild hypercalcemia is recommended. These individuals are advised to avoid dehydration and limit dietary calcium intake. Definitive treatment of severe primary hyperparathyroidism involves surgical removal of a solitary adenoma, or, in the case of a hyperplasia, complete removal of 3 and partial removal of the 4th hyperplastic parathyroid gland. Imaging procedures are used to localize adenomas before surgery. In those individuals who fail surgery, other treatments, such as a biphosphonate and calcimimetics, may be considered. Calcimimetics increase the parathyroid calcium receptor sensitivity, thus lowering PTH levels. If hypercalcemia is documented, but PTH levels are low, the differential diagnosis shifts to hypercalcemia of malignancy, granulomatous disease, sarcoidosis, excessive calcium ingestion, or hypervitaminosis A or D. Treatment of these conditions depends on the underlying cause. If the serum calcium level is low, but PTH level is elevated, secondary hyperparathyroidism is likely. Evaluation for renal function frequently documents chronic renal disease. Treatment for secondary hyperparathyroidism in chronic kidney disease requires calcium replacement, dietary phosphate restrictions, and phosphate binders, and vitamin D replacement. Treatment also may include calcimimetrics, but adverse effects must be considered. So let's go the opposite route now to hypoparathyroidism. Your hypoparathyroidism, abnormally low PTH levels, most commonly is caused by damage to or the removal of the parathyroid gland during thyroid surgery and occurs because of the anatomic proximity of the thyroid glands to the thyroid. Hypoparathyroidism also is associated with genetic syndromes, including familial hypoparathyroidisms and DiGeorge syndrome, and an idiopathic or autoimmune form of the disease. Hypomagnesemia also can cause a decrease in PTH secretion and function. There is an inherited condition associated with hypocalcemia with normal to elevated PTH called pseudohypoparathyroidism. Individuals with this condition are resistant to PTH in the proximal renal tubule and cannot produce cAMP in response to PTH. So you have a post-receptive defect in your PTH action. So, pathophysiology. A lack of circulating PTH causes depressed serum calcium levels and increased serum phosphate levels. In the absence of PTH, resorption of calcium from bone and regulation of calcium reabsorption from the renal tubules are impaired. Therefore, phosphate reabsorption by the renal tubules is increased, causing decreased renal phosphate excretion and hyperphosphatemia. Hypomagnesemia inhibits PTH secretion. With serum magnesium levels returning to normal, however, your PTH secretion returns to normal, as does the responsiveness of peripheral tissues to PTH. Hypomagnesemia may be related to chronic alcoholism, malnutrition, malabsorption, increased renal clearance of magnesium caused by the use of aminoglycoside, antibiotics, or certain chemotherapeutic agents, or prolonged magnesium-deficient parenteral nutritional therapy. So, our clinical manifestations. Symptoms associated with hypoparathyroidism are primarily those of hypocalcemia. Hypocalcemia causes a lowered threshold for nerve and muscle excitation, so that a nerve impulse may be initiated by a slight stimulus anywhere along the length of the nerve or muscle fiber. This creates perioral numbness, paresthesias, tingling, and tetany caused by muscle spasms, hyperreflexia, tonic-clonic convulsions, laryngeal spasms, and in severe cases, death from asphyxiation. Schwostek and Trousseau signs may be used to evaluate for neuromuscular irritability. Schwostek sign is elicited by tapping the cheek, resulting in twitching of the upper lip. Trousseau sign is elicited by sustaining inflation of a sphygmomanometer placed on the upper arm to a level above the systolic blood pressure, with resultant painful carpal spasms. Other symptoms of hypocalcemia include dry skin, loss of body and scalp hair, hypoplasia of developing teeth, horizontal ridges on the nails, cataracts, basal ganglia calcifications, and bone deformities, including brachydactyl and bowing of the long bones. Phosphate retention caused by increased renal reabsorption of phosphate is associated also with hypoparathyroidism. Hyperparathyroidism, hyperphosphatemia results from PTH deficiency, and in turn, hyperphosphatemia further lowers calcium concentration by inhibiting the activation of vitamin D, thereby lowering the gastrointestinal absorption of calcium. So what is our evaluation and treatment? A low serum calcium level and a high phosphorus level in absence of renal failure, intestinal disorders, nutritional deficiencies, or in individuals who have had a thyroidectomy suggest hypoparathyroidism. Your PTH levels are low in hypoparathyroidism, and measurement of serum magnesium and urinary calcium excretion can help in diagnosis. Treatment is directed towards the alleviation of hypocalcemia. In acute states, this involves parenteral administration of calcium, which corrects serum calcium concentration within minutes. Maintenance of serum calcium level is achieved with pharmacologic doses of active form of vitamin D and oral calcium. Hypoplastic dentition, cataracts, bone deformities, and basal ganglia calcifications do not respond to the correction of hypocalcemia, but other symptoms of hypocalcemia are reversible. PTH hormone replacement therapy with recombinant human parathyroid hormone is safe and effective, with reduced requirements for supplemental calcium and vitamin D. As serum calcium levels return to normal, phosphaturia usually is stimulated with the return to normal serum phosphate levels. In some individuals, however, the absence of phosphaturic effects of PTH causes a persistent hyperphosphatemia, which should be treated with drugs that inhibit gastrointestinal absorption of phosphate. So, your dysfunction of the endocrine, your pancreas, your classic diabetes, type 1 and type 2. Diabetes is a group of metabolic diseases characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or a combination of both. In 2015 in the US, an estimated 30 million people had diabetes and 7 million were estimated to be undiagnosed. diabetes is the seventh leading cause of death. The American Diabetes Association classifies four categories of diabetes. Oh, now there's four. So, the classification and characteristics of diabetes. I'll leave that up for a moment. You can always pause the video. Alright, so of the four types, type 1 beta cell destruction, usually leading to absolute insulin deficiency. Type 2, ranging from predominantly insulin resistance with relative insulin deficiency to predominantly an insulin secretory defect with insulin resistance. Type 3 are other specific types, very specific there, and gestational diabetes. The diagnosis of diabetes mellitus is based on a glycosylated hemoglobin, your HbA1c levels, your fasting plasma glucose, and a 2-hour plasma glucose level during oral glucose tolerance testing using a 75-gram oral glucose load or random glucose levels in individuals with symptoms. Usually that test is done during pregnancy. Your glycosylated hemoglobin refers to the permanent attachment of glucose to hemoglobin molecules, and it reflects the average plasma glucose exposure over the life of a red blood cell, roughly 120 days. It provides a more accurate measurement of monitoring the long-term control of blood glucose levels. This test is critical, dependent upon the method of measurement, and must be related to established standards. Your hemoglobin A1C. So I'll leave that up for just a moment. Again, pause if you need it. The ADA classification categorizes of increased risk for diabetes, describes non-diabetic elevation of a hemoglobin A1C, FPG, or the 2-hour plasma glucose value during OGTT. The Centers for Disease Control and Prevention, or CDC, estimates that about 37% of US adults aged 20 years or older have a type of prediabetes, including 51% of those aged 65 years or older. This classification includes impaired glucose tolerance, which results from diminished insulin secretion, and impaired fasting glucose, which is caused by enhanced hepatic glucose output secondary to hepatic insulin resistance. Individuals with IGT and IFG are at increased risk for cardiovascular disease and a premature death, and carry a 15 to 50% 5-year risk of developing diabetes, particularly type 2. Thus, prevention of diabetes with lifestyle interventions is essential. Type 1. Type 1 is the most common pediatric chronic disease and affects about 0.17% of US children. And the incidence is increasing. Between 10 to 13% of individuals with newly diagnosed type 1 diabetes have a first-degree relative, a parent and or a sibling with type 1 diabetes. There's a 50% concordance rate in twins. Diagnosis is rare during the first 9 months of life and peaks at 12 years of age. Two distinct types of type 1 diabetes have been identified: an autoimmune and idiopathic or non-immune. Type 3C diabetes is associated with chronic pancreatitis and is discussed in chapter 42. So this next table here summarizes the epidemiology of type 1 and type 2. Again, pause the video if you need the comparison side by side, otherwise I will continue to let it slowly slide down. So, what is pathophysiology of type 1 diabetes? In an autoimmune mediated diabetes, environmental genetic factors are thought to trigger cell mediated destruction of pancreatic beta cells. A specific cause is still unknown. Idiopathic or non-immune type 1 diabetes is far less common than autoimmune and, and does not have an autoimmune basis for beta cell destruction. It occurs secondary to other diseases, such as pancreatitis, and mostly in people of Asian or African descent. Affected individuals have varying degrees of insulin deficiency, lack islet autoantibodies and HLA association, and have intermittent proneness to ketosis. Proneness. Wow. Uh, the word is proneness to ketosis. It also is described as ketosis-prone type 2 diabetes. Wow. So, what kind of gene environmental factors would we expect to see? Well, your interactions between environmental factors and susceptibility genes are thought to have a significant contribution to the development of type 1 diabetes, but the mechanisms are still poorly defined. The strongest genetic association is with major histocompatibility complex, or MHC, class II alleles, HLA-DR3, DQ2, or HLA-DR4, DQ8 haplotypes, or both. Numerous other mutations involving single genes, both within and outside the MHC complex, have been associated with an increased risk of type 1 diabetes. Various epigenetic modifications of gene expression also have been postulated. Environmental factors, including viral infection, particularly enterovirus, Coxsackie virus, or other infectious microorganisms like your Heliobacter pylori, exposure to cow's milk protein, a relative lack of vitamin D, air pollution, vaccination, stress, gut microbial flora, and family density have all been implicated, but more research is still needed. So your immunologically mediated destruction of beta cells. Autoimmune type 1 diabetes is slowly progressive autoimmune T cell mediated disease that destroys the beta cells of the pancreas and occurs genetically susceptible individuals. Again, see chapter 9, you'll see more about that. There is a deficient immune tolerance linked to abnormality in immune cells and changes in beta cell antigens. Your gene environment interactions result in a loss of tolerance to self-antigens, with the formation of autoantigens that are expressed on the surface of pancreatic beta cells and circulate in the bloodstream and in lymphatics. Cellular immunity and humoral immunity are stimulated, resulting in beta destruction and apoptosis. So I'll leave this picture up for just a moment. It shows the pathophysiology of type 1 diabetes. The destruction of beta cells progress through the following stages. First, you have your lymphocyte and macrophage infiltration of the islets, resulting in inflammation and islet beta cell death. Your autoantigens are expressed on the surface of pancreatic islet cells and circulate in the bloodstream and lymphatics. Circulating autoantigens are ingested by antigen-presenting cells that activate the CD4 plus T helper 1 lymphocytes. The activated T helper lymphocytes secrete interleukin 2 that activates beta cell autoantigen specific T cytotoxic lymphocytes, causing them to proliferate and attack islet cells through secretion of toxic perforins and granzymes. T helper lymphocytes also secrete interferon that activate macrophages and stimulates the release of inflammatory cytokines, including interleukin 1 and tumor necrosis factor, which cause further beta cell destruction and apoptosis. Then stage 2 kicks in, the production of autoantibodies against islet cells, insulin, glutamic acid, decarboxylase, and other cytoplasmic proteins. Activated T helper 2 lymphocytes produce interleukin 4, which stimulates beta or B lymphocytes to proliferate and produce antibodies. Islet cells, autoantibodies, precede evidence of beta cell deficiency and can be found in serum years before symptoms can occur. Your beta cell destruction also is mediated by the production of autoantibodies against insulin, glutamic acid, decarboxylase, and tyrosine phosphatase. Finally, another islet antigen against which antibodies are produced is type 1 and type 2 diabetes, is the zinc transporter 8 protein. It can be measured in the serum and is associated with variation in disease progression. Then part 3 finally kicks in. Relative inactivity of T regulatory cells that contribute to a decrease in beta cell mass and insulin production. Normally, these T lymphocytes serve to inhibit the immune response and maintain self-tolerance. So, for insulin synthesis to decline enough such that hyperglycemia occurs, 80 to 90% of the insulin secreting beta cells of the islets of Langerhans must be destroyed. Insulin normally suppresses secretion of glucagon, and thus hypoinsulinemia leads to a marked increase in glucagon secretion. Glucagon, a hormone produced by the alpha cells of the islets, act in the liver to increase blood glucose levels by stimulating glycogenolysis and gluconeogenesis. In addition to the decline in insulin secretion, there is a decreased secretion of amylin, another beta cell hormone. One of the critical actions of amylin is to suppress glucagon release from the alpha cells. Thus, both alpha cell and beta cell functions are abnormal, and both a lack of insulin and a relative excess of glucagon contribute to the hyperglycemia in type 1 diabetics. So what are our clinical manifestations? The onset of type 1 diabetes involves a long preclinical period with gradual destruction of beta cells, eventually leading to insulin deficiency and eventually leading to hyperglycemia. Generally, this latent period is longer in older individuals with type 1 diabetes and often results in misclassification of those affected as having a type 2 diabetes. This is sometimes called a latent autoimmune diabetes of adults. Type 1 diabetes affects the metabolism of fat, protein, and carbohydrates. Glucose accumulates in the blood and appears in the urine as the renal threshold of glucose is exceeded, producing an osmotic diuresis manifested as polyuria and thirst. Wide fluctuations in blood glucose levels occur. In addition, protein and fat breakdown occurs because of the lack of insulin, resulting in weight loss. Increased hepatic metabolism of fat leads to high levels of circulating ketones, causing a diabetic ketoacidosis. So here are some clinical manifestations for type 1 diabetes. Again, pause if you need to see them specifically rationed or rationaled out to you, but you will have your polydipsia, polyuria, polyphagia, your weight loss, and fatigue. Currently, half of the individuals with type 1 diabetes are obese, and there is an increasing number of individuals who have both one type 1 diabetes and clinically, oh boy, who have both type 1 diabetes and the clinical manifestations of metabolic syndrome, including dyslipidemia and hypertension. This is because, in part, of successful intensive insulin therapy that promotes weight gain, and also in part because of lifestyle factors, including lack of exercise and poor nutrition. This creates a high risk of synergistic effects of chronic complications of diabetes, including heart disease and stroke. And adjunctive, non-insulin, anti-hyperglycemic therapies are under investigation. So what is our evaluation and treatment? For type 1 diabetes, the criteria for diagnosis of type 1 diabetes are the same as those for type 2. The diagnosis of diabetes is not difficult when there are symptoms of polydipsia, polyuria, polyphagia, weight loss, and hyperglycemia are present in fasting and postprandial states. Many children are first diagnosed when they present with the signs and symptoms of DKA. It reflects lack of awareness by parents and primary care providers of the evolving symptoms of type 1 diabetes. In DKA, acetone is exhaled by hyperventilation and gives the breath a sweet or fruity odor. Occasionally, diabetic coma is the initial symptom of the disease. C-peptide, a component of proinsulin release during insulin production, can be measured in the serum as a surrogate for insulin levels and is indicative of residual beta cell mass and function. The zinc transporter 8 autoantibody test has been approved to help differentiate type 1 from type 2. Currently, measurements of autoantibodies remain the best way to identify diabetes and to distinguish type 1 diabetes from other forms of diabetes. Having 2 or more islet autoantibodies confer a 100% risk of diabetes development. Other important aspects of evaluation include assessing for evidence of the chronic complications of diabetes. There are no approved therapies for preventing beta cell mass. Many different kinds of approaches are being tested to prevent autoimmune destruction of beta cells that is characteristic of type 1 diabetes. Avoidance of cow's milk, utilization of gluten-free diet, and increased intake of omega-3 fatty acids and vitamin D are all being explored. Pharmacologic prevention trials include immunosuppression and immunomodulation therapies. The treatment regimen are designed to achieve optimal glucose control without causing episodes of significant hypoglycemia. Management requires individual planning according to the type of disease, age, and activity level. All individuals with type 1 diabetes require some combination of insulin therapy, meal planning, exercise program, and self-monitoring of blood glucose levels. Several different types of insulin preparations and new technologies for more physiologic insulin delivery systems are available. The use of pramlintide, a synthetic analog of amylin, can replace this hormone in individuals with type 1 and type 2 diabetes. Blood glucose monitoring is an essential part of management, and there are numerous types of monitoring devices for both self and real-time blood glucose monitoring. Individuals also should be screened at least yearly for complications of diabetes. Finally, islet cells, stem cells, and whole pancreas transplantation have been successful in selected individuals. Type 2 diabetes. Type 2 diabetes affects 9.3% of adults in the United States. Prevalence is highest among American Indians and Alaska Natives, and lowest among non-Hispanic whites. There also is an increased prevalence in type 2 diabetes in children, especially obese children. A genetic environmental interaction appears to be responsible for type 2 diabetes. The most well-recognized risk factor are age, obesity, hypertension, physical inactivity, and family history. There is increased evidence that diet, including diet during pregnancy, influences long-term risk of type 2 diabetes in children and adults. More than 65 genes have been identified that are associated with type 2 diabetes, including those that code for beta cell mass, beta cell function. Your proinsulin and insulin molecular structure. Insulin receptors, hepatic synthesis of glucose, glucagon synthesis, and cellular responsiveness to insulin stimulation. Metabolic syndrome is a constellation of disorders that together confer a high risk of developing type 2 diabetes and associated cardiovascular complications. So if you take a look at box 22.3, it lists them. The metabolic syndrome developed during childhood is highly prevalent among overweight children and adolescents and affects millions of adults. Metabolic syndrome is characterized by many of the same genetic and environmental risks as type 2 diabetes, and individuals should be screened on a regular basis. Early recognition and treatment include vigorous lifestyle changes, are critical to reducing cardiovascular events and improving clinical outcomes. So, the pathophysiology. Many organs contribute to insulin resistance, chronic hyperglycemia, and consequences of type 2 diabetes. The combination of genetic and environmental influences result in the basic pathophysiologic mechanism of type 2 diabetes. So I'll leave this picture up for just a moment and we'll keep on keeping on. So, insulin resistance is defined as suboptimal response to insulin-sensitive tissues to insulin and is associated with obesity. Several mechanisms are involved in abnormalities of the insulin signaling pathway and contribute to insulin resistance. These include an abnormality of the insulin molecule, high amounts of insulin antagonists, downregulation of insulin receptor, decreased or abnormal activation of post-receptor kinases, and alteration of glucose transporter proteins. Obesity is one of the most important contributors to insulin resistance and diabetes and acts through several important mechanisms. Your adipokines, your leptin and adiponectin, are hormones produced in white adipose tissue. Obesity results in increased serum levels of leptin, decreased levels of adiponectin, and inflammation. These changes are associated with a decreased insulin synthesis and insulin resistance. Number 2, elevated levels of serum-free fatty acid and intracellular deposits of triglycerides and cholesterol are found in obese individuals. These changes interfere with intracellular insulin signaling, decrease tissue response to insulin, alter incretin action, promote inflammation, and cause apoptic beta cell death. This is known as lipotoxicity. Number 3, obesity causes a release of inflammatory cytokines, your tumor necrosing factor alpha and interleukin 6, from intra-abdominal adipocytes or adipocyte-associated mononuclear cells, and from activated macrophages that release inflammatory cytokines. These cytokines induce insulin resistance through a post-receptor mechanism and play an important role in the genesis of fatty liver, atherosclerosis, and dyslipidemia. Alterations in oxidative phosphorylation in cellular mitochondria have been documented, resulting in reduced insulin-stimulating mitochondrial activity and insulin resistance, especially in skeletal muscle and hepatocytes. However, the mechanisms are not clearly defined. And lastly, number 5, obesity is correlated with hyperinsulinemia and impaired insulin receptor signaling. Compensatory hyperinsulinemia prevents the clinical appearance of diabetes for years. Eventually, however, your beta cell dysfunction develops and leads to a relative deficiency of insulin activity. The islet dysfunction is caused by a combination of a decrease in beta cell mass and reduction in beta cell function. A progressive decrease in the weight and number of beta cells occurs, and many of the remaining cells develop exhaustion, from increased demand for insulin biosynthesis. Your glucagon concentration is increased in type 2 diabetes because pancreatic alpha cells become less responsive to glucose inhibition, resulting in an increase in glucagon secretion. These abnormally high levels of glucagon increase blood glucose level by stimulating glycogenolysis and gluconeogenesis, as was discussed under type 1 diabetes. Type 2 diabetes also is associated with a deficiency in amylin, further increasing glucagon levels. Your amylin, your islet of amyloid polypeptide, is another beta cell hormone that is decreased in both type 1 and type 2 diabetes. Amylin increases satiety and suppresses glucagon release from the alpha cells. Amylin contributes to islet cell destruction through the deposition of abnormal amyloid polypeptide within the pancreas. As in type 1 diabetes, pramlintide, a synthetic analog of amylin, is used for treatment in type 2 diabetes. Hormones from gastrointestinal tract play a role in insulin resistance, beta cell function, and diabetes. Ghrelin is a peptide produced in the stomach and pancreatic islets that regulate food intake, energy balance, and hormonal secretion. At decreased levels of circulating ghrelin have been associated with insulin resistance and increased fasting insulin levels. Its use as a potential treatment for type 2 diabetes is being investigated. The incretins are a class of peptides that are released in the GI tract in response to food intake and function to increase synthesis and secretion of insulin and beta cell proliferation and regeneration, and protection against beta cell damage. The most studied incretin is glucagon-like peptide 1, GLP-1, and studies have demonstrated that GLP-1 is reduced both in prediabetes and type 2 diabetes. So what are our clinical manifestations? Your clinical manifestations of type 2 diabetes are nonspecific. The affected individuals often is overweight, dyslipidemic, hyperinsulinic, and hypertensive. Classic symptoms include polyuria and polydipsia. May present, but more often individuals will have nonspecific symptoms such as fatigue, pruritus, recurrent infection, visual changes, or symptoms of neuropathy. In those whose diabetes has progressed without treatment, symptoms related to coronary artery, peripheral artery, and cerebrovascular disease may also develop. So, if you're looking here at some more manifestations of what you could see with type 2 diabetes, hit the pause button and you can read it. Your evaluation and treatment, therefore, the diagnostic criteria for type 2 diabetes are the same as for type 1. The diagnostic criteria for prediabetes also has been defined. Your prevention of type 2 diabetes, especially in those individuals with prediabetes, hinges on diet and exercise, although there is an increasing support for the use of some diabetes medications in high-risk individuals. As with type 1, the goal of treatment for individuals with type 2 is the restoration of near euglycemia and correction of related metabolic disorders. Your weight loss results in improved insulin sensitivity and glucose tolerance, preserves beta cell function, and has an inhibitory effect on progression to type 2 diabetes. Diet should match activity levels and include more complex carbohydrates rather than simple sugars. Foods low in fats, adequate protein, and fiber. Bariatric surgery may be indicated for individuals with morbid obesity who are unresponsive to diet and exercise interventions, although long-term studies are needed to evaluate sustained effectiveness. So, if you would like to read on what's new on type 2 diabetes, please again hit that pause button and you can read that little section. Exercise reduces postprandial blood glucose levels, diminishes insulin requirements, lowers triglycerides and cholesterol levels, and increases the level of high-density lipoprotein cholesterol. Hypoglycemia may result, however, when the exercising individual receives sulfonylurea or insulin therapy. Exercise also can be associated with a decreasing response of counter-regulatory hormones to hypoglycemia. For individuals who require further intervention, oral hypoglycemic agents are indicated. Currently, there are 9 classes of oral agents available. Metformin is considered the primary pharmacologic choice of treatment for type 2 diabetes, and a second oral agent, a GLP-1 receptor agonist or basal insulin, is added if the hemoglobin A1C target is not maintained over 3 months. A combination of drugs may be required. Insulin therapy may be needed in the later stages of type 2 diabetes because of the loss of beta cell function, which is progressive over time. Renal reabsorption of glucose through the sodium glucose cotransporter 2 is an important controller of serum glucose levels, and new medications aimed at blocking it have resulted in decreased measurements of blood glucose levels, weight, blood pressure, and uric acid level. However, there is an increased risk for ketoacidosis, and the safety profile continues to be evaluated. There are standards of care to guide the management of type 2 diabetes. So again, there are different types of medications. Go ahead and hit the pause button if you want to look at specifics, especially the mechanisms of action. You also can hit pause if you want to read the selective sodium glucose cotransporter 2, inhibitors for type 2 diabetes therapy. So, other specific types of diabetes and gestational diabetes. As listed in Table 22.5, the American Diabetes Association classification of diabetes encompasses not only the most common forms of diabetes, 1 and 2, but also other specific types of diabetes and gestational diabetes. The other specific types of diabetes include genetic defects in beta cell function, genetic defects in insulin action, diseases of the exocrine pancreas, like your cystic fibrosis, your endocrinopathy, drug or chemically induced beta cell dysfunction, infections, and other uncommon autoimmune or inherited disorders that are associated with diabetes. The best described of these other specific types of diabetes is termed maturity onset diabetes of youth, also known as MODY. MODY classically presents as non-insulin requiring diabetes in lean individuals, typically younger than 25, with evidence of autosomal dominant inheritance. MODY is a monogenic form of diabetes and accounts for about 1 to 2% of diabetes, and should be considered in children who lack beta cell antibodies. It also may account for up to 5% of individuals diagnosed with gestational diabetes. MODY includes 6 specific autosomal dominant mutations, including genes for hepatocyte nuclear factor 1 alpha, dash 4A, glucokinase, and less commonly insulin promoter factor 1, and NeuroD1, important for the development or function of beta cells. The clinical diagnosis of MODY is based on the following criteria: a family history of diabetes with an autosomal dominant mode of inheritance, insulin independence in non-ketotic diabetes mellitus, and age of onset younger than 25 years of age. Genetic testing confirms the diagnosis. Management is similar to those techniques used in type 2 diabetes. Leading us to gestational diabetes has been defined as any degree of glucose intolerance with onset of first recognition during pregnancy. However, this definition meant that many women with previous undiagnosed type 1 or type 2 were diagnosed with gestational diabetes, and many of them had progressive disease after diagnosis. Therefore, the American Diabetes Association recommends that high-risk women found to have diabetes at their initial prenatal visit receive a diagnosis of type 1 or type 2 diabetes. Your GDM complicates approximately 7% of all pregnancies. The exact mechanism of GDM is unknown, but insulin resistance and inadequate insulin secretion are contributing factors both before and during pregnancy. Insulin sensitivity declines with advancing gestation in normal pregnancy, but euglycemia is maintained by increasing insulin secretion. The ADA recommends that pregnant women with risk factors be screened for type 2 diabetes their first prenatal visit. Those without a history of diabetes should be screened with an oral glucose tolerance test at 24 to 28 weeks of gestation. Often, there are no symptoms, and careful glucose level control prenatally during pregnancy and after delivery is essential. Women who had a pregnancy affected by gestational diabetes and normal results on postpartum screening should be screened at 6 to 12 weeks after delivery with repeat testing every 1 to 3 years depending on the risk factors. Your gestational diabetes results in increased risk for type 2 and long-term metabolic and cardiovascular complications later in life for both the mother and the baby. Your acute complications of diabetes. The major acute complications of diabetes are hypoglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic non-ketotic syndrome. So your DKA versus your HHNS contains this table at 22.10 contains a comparison of the diabetes. Morning hyperglycemia in diabetic subjects may be caused by the Somogyi effect, the dawn phenomenon, or poor glycemic control. The Somogyi effect is the occurrence of hypoglycemia at about 3 a.m. caused by too much intermediate-acting insulin, NPH, given at dinner time, followed by rebound hyperglycemia caused by normal early morning secretion of counter-regulatory hormones, epinephrine, growth hormone, and corticosteroids, which are stimulated by the hypoglycemia and cause gluconeogenesis. Excessive carb intake may contribute to the rebound hyperglycemia. The treatment is to decrease evening insulin levels. The Somogyi effect is becoming much less common because of the increasing use of long-acting bioengineered insulin. The dawn phenomenon is an early morning rise in blood glucose concentration caused by nocturnal elevations of growth hormone, which decrease metabolism of glucose by muscle and fat. Increasing the dose of evening insulin manages the problem. Again, here is that table. Feel free to hit pause, and you can read all the different aspects of it. So that leads us now in the opposite end of diabetes, your hypoglycemia. Hypoglycemia occurs when blood glucose levels are less than 47 milligrams per deciliter in newborns for the first 48 hours of life, and less than 70 milligrams per deciliter in children and adults. Its causes may be exogenous, medication, alcohol, or exercise, or endogenous, tumors of the pancreas or inherited disorders, or functional, your hyperalimentation, spontaneous or liver disease. So hypoglycemia in diabetes is sometimes called insulin shock or insulin reaction. Individuals with type 2 diabetes are at less risk for hypoglycemia than those with type 1 diabetes because they retain a relative intact glucose counter-regulatory mechanism. However, hypoglycemia does occur in type 2 diabetics when treatment involves SGLT2 inhibitors, GLP-1 receptor agonists, sulfonylureas, thiazolidinediones, and exogenous insulin, particularly when used in combination. Symptoms of hypoglycemia result either from activation of the sympathetic nervous system or from the abrupt cessation of glucose delivery to the brain, or both. Neurogenic reaction occur when the decrease in blood glucose levels is rapid and presents with tachycardia, palpitations, diaphoresis, tremors, pallor, and arousal anxiety. Other symptoms include a headache, dizziness, blurred vision, irritability, fatigue, poor judgment, confusion, hunger, seizure, and coma. Hypoglycemia unawareness is a phenomenon that occurs in individuals without appropriate autonomic warning systems, and recovery from hypoglycemia may be delayed because of impaired glycogenolysis and hampered delivery of gluconeogenic substrates to the liver. Treatment requires immediate replacement of glucose, either orally or intravenously. Glucagon for home use can be prescribed for individuals who are at higher risk. Prevention is achieved with individualized management of medications and diet, monitoring of blood glucose levels, and education. So that makes us now jump back into the high end of things. Your diabetic ketoacidosis. Diabetic ketoacidosis is a serious complication related to a deficiency of insulin and an increase in the levels of insulin counter-regulatory hormones, your catecholamines, cortisol, glucagon growth hormone. DKA occurs in approximately 30% of children with type 1 diabetes and 5% of children with type 2. DKA is most common in individuals with type 1 diabetes because insulin is more deficient. It rarely occurs in those with type 2 diabetes and occurs most frequently in obese non-Hispanic blacks. The most common precipitating factor for DKA is intercurrent illness, such as infection, trauma, surgery, myocardial infarction, poor adherence to insulin treatment, or interruption of insulin administration also may result in DKA. Factors associated with an increased risk of type 1 diabetes: poor glycemic control, younger or older age, diagnostic error, ethnic minority, lack of health insurance in the US, lower body mass index, preceding infection, and delayed treatment. So what is the pathophysiology of DKA? The most important pathophysiologic mechanism for DKA are insulin deficiency and an increase in counter-regulatory hormones. Again, the catecholamines, cortisol, glucagon, and growth hormone. The counter-regulatory hormones normally antagonize insulin by increasing glucose production and decreasing tissue use of glucose. Profound insulin deficiency results in decreased glucose uptake, increased fat mobilization with release of fatty acids, and accelerated gluconeogenesis, glycogenesis, and ketogenesis. In the absence of insulin, the release of free fatty acids from adipocytes increased production of ketone bodies by the mitochondria of the liver at a rate that exceeds peripheral use. Accumulation of ketone bodies drops the pH and triggers the buffering system associated with metabolic acidosis. Your DKA causes caused by increased levels of circulating ketones in the absence of the anti-lipolytic effect of insulin occurs. Relatively, increased glucagon levels also contribute to the activation of gluconeogenetic and ketogenic pathways in the liver. Ordinarily, ketones are used by tissue as an energy source to regenerate bicarbonate. This balance and loss of bicarbonate, which occurs when the ketone is formed, hyperketonemia, may result from impaired use of ketones by peripheral tissue, which permits strong organic acids to circulate freely. Your bicarbonate buffering then does not occur, and the individual develops a metabolic acidosis. So there you see the physiologic pathway of DKA and HHNKS. I'll leave that up for just a moment while I continue reading. Clinical manifestations. The signs and symptoms of DKA include Kussmaul respirations, that hyperventilation in an attempt to compensate for the acidosis, postural dizziness, central nervous system depression, ketonuria, anorexia, nausea, vomiting, abdominal pain, an acetone odor on the breath, dehydration, thirst, and polyuria. Polyuria and dehydration result from the osmotic diuresis associated with hyperglycemia. In this case, the plasma glucose level is higher than the individual's renal threshold, allowing significant amounts of glucose to be lost in the urine. Deficits of sodium, phosphorus, and magnesium is common. The most important electrolyte disturbance is a marked deficiency in the level of total body potassium. Although the serum potassium concentration may appear normal or elevated because of the volume contraction and the shift of potassium out of the cell and into the blood caused by metabolic acidosis, the total body deficiency of potassium may reach 3 to 5 MEq per kilo. So what is our evaluation of and treatment of DKA? The diagnosis of DKA is suggested when individuals have symptoms described earlier. The American Diabetes Association criteria for diagnosing DKA include a glucose level greater than 250, a serum bicarb level less than 18, and a serum pH less than 7.30, the presence of an anion gap, and the presence of urine and serum ketones. Treatment of DKA involves administration of insulin to decrease glucose levels. Fluids are administered to replace lost fluid volume. Electrolyte deficits become apparent as fluid volume is replaced, and IV sodium, potassium, and phosphorus are administered as needed. Potassium moves with insulin into the cell and contributes to hypokalemia. Volume status and serum electrolytes, particularly potassium, should be monitored closely. The administration of insulin and concentration of beta-hydroxybutyrate promptly begins to decrease, and after a slight increase, acetoacetate concentrations also begin to decrease. A persistent ketonuria may be observed for several days after treatment. Continuous monitoring of the individual is essential to ensure an uncomplicated recovery of DKA. Health teaching emphasizes predisposing factors and strategies for avoiding DKA. That now leads us to the hyperosmolar hyperglycemic non-ketotic syndrome, also known as HHNS. HHNS is an uncommon but significant complication of type 2 diabetes with a high overall mortality. It occurs more often in elderly individuals who have other comorbidities, including infection or cardiovascular or renal disease. Your pathophysiology. HHNS differs from DKA in the degree of insulin deficiency and the elevation of glucose levels and degree of fluid deficiency. HHNS has synergistic factors, including insulin deficiency and increased levels of counter-regulatory or stress hormones, with increased gluconeogenesis and glucogenolysis, and inadequate use of glucose by peripheral tissues, primarily your muscle, characterized by a lack of ketosis. Your pro-inflammatory mediators, your tumor necrosing factor alpha, interleukin 6, and interleukin 1 beta, also promote insulin resistance and release of counter-regulatory hormones, contributing to insulin resistance and hyperglycemia. Because the amount of insulin required to inhibit fat breakdown is less than that needed for effective glucose transport, insulin levels are sufficient to prevent excessive lipolysis, but not to use glucose properly. So our clinical manifestations, your glycosuria or polyuria in HHNS result from an extreme serum of glucose level elevation. As much as 19 grams of glucose per hour may be lost in diuresis, which causes severe volume depletion, increased serum osmolarity, intracellular, intracellular dehydration, and loss of electrolytes including potassium. Neurologic changes such as stupor correlate with a degree of hyperosmolarity and are common in HHNS. Thus, this syndrome is sometimes called hyperosmolar hyperglycemic coma. Treatment and evaluation. Your diagnostic features of HHNS include a very high serum glucose concentration, often more than 600, a near normal serum bicarb level, and pH, a serum osmolarity that is usually greater than 320 mOSM per liter, and either absent or low levels of ketones in the urine and in the serum. DKA and HHNS show considerable overlap in symptoms and treatment. Insulin infusion should be combined with fluid repletion over 24 hours. An important distinction, however, is that the dehydration in HHNS is far more severe than that in DKA. Thus, fluid replacement with both crystalloid and colloids is more rapid. Potassium deficits may be extreme and require several days of treatment. Phosphorus and sodium also may be needed. HHNS is a significant risk factor for infection, sepsis, and venous thrombosis. Your mortality is between 10 and 20% and is related to the age of the individual and comorbid condition, including the severity of the precipitating illness. All right, that leads us to chronic complications of diabetes. Chronic complications of diabetes mellitus. A number of serious complications are associated with any type of poorly controlled diabetes, insulin resistance or deficit, chronic hyperglycemia, accumulation of advanced glycation end products, and activation of metabolic pathways that cause tissue damage resulting in the chronic complications of diabetes mellitus. These complications include microvascular and macrovascular disease. Strict control of blood glucose levels significantly reduces some complications, particularly non-fatal myocardial infarction. Strict control is not recommended for high-risk individuals with type 2 diabetes because it is associated with increased all-cause mortality, cardiovascular mortality, and severe hypoglycemia. However, the individual's risk-benefit profile should be considered. Oxidative stress, the overproduction of reactive oxygen species, activation of several complex metabolic pathways, and inflammation have been associated with persistent hyperglycemia, insulin resistance, hyperinsulinemia, dyslipidemia, and chronic complications of diabetes. They include shunting of glucose into the pyrrole pathway, activation of protein kinase C isoforms, increased formation of advanced glycation end products, increased expression of the receptor for age or rage, and increased activation of hexosamine pathway. It has been proposed that hyperglycemia induces mitochondrial overproduction of oxygen-free radicals, and this is a key pathologic mechanism for the activation of the metabolic pathway associated with arthrogenesis and damage to large and small vessels. Genetic epigenetic factors also contribute to the complication of diabetes. Tissues that do not require insulin for glucose transport, such as kidneys, red blood cells, blood vessels, eye lens, and nerves, cannot downregulate the cellular uptake of glucose. Consequently, with hyperglycemia, intracellular glucose is shunted into an alternate metabolic pathway for glucose metabolism, known as pyrrole pathway. Overactivation of the pyrrole pathway results in two processes that may contribute to the complication of diabetes. One is excessive accumulation of sorbitol through the action of the enzyme aldose reductase. The accumulated sorbitol increases intracellular osmotic pressure and attracts water in tissues. Swelling occurs along the visual changes and predisposition to cataracts in the lens of the eye. Sorbitol interferes with the ion pump in the nerves, damages Schwann cells, and disrupts nerve conduction. Red blood cells become swollen and stiff and interfere with perfusion. Second activation of the pyrrole pathway reduces glutathione, an important antioxidant, contributing to oxidative injury in cells and tissues, particularly blood vessels. Aldose reductase inhibitors are being evaluated for treatment of these complications. Your protein kinase C is a family of intracellular signaling proteins that can become inappropriately activated in different tissues by hyperglycemia. Intracellular hyperglycemia increases the second messenger diacylglycerol pathway, which in turn activates protein kinase C. Various consequences have been observed, including insulin resistance, extracellular matrix and cytokine production, vascular cell proliferation, enhanced contractility, angiogenesis, and increased permeability. These effects may contribute to the microvascular complications of diabetes. Glycation is a normal, non-enzymatic process that involves the reversible attachment of glucose to proteins, lipids, and nucleic acids. With recurrent or persistent hyperglycemia, glucose becomes irreversibly bound to collagen and other proteins in red blood cells. Blood vessel wall, interstitial tissue, uh, and within cells. The products of binding are known as advanced glycation end products, AGEs, and the receptors RAGE. A number of proportions or properties may cause tissue injury and pathologic conditions associated with diabetes, such as 1. The cross-linking and trapping of proteins including albumin, low-density lipoprotein, immunoglobulin, and complement the thickening of the basement membrane, or increased permeability in small blood vessels and nerves, binding to cell receptors such as macrophages and glomerular mesenchymal cells, inducing release of inflammatory cytokines and growth factors that stimulate cellular proliferation in the glomeruli, smooth muscle of blood vessels, and collagen synthesis with fibrosis, induction of lipid oxidation, oxidative stress, and inflammation, inactivation of nitric oxide with loss of vasodilation and diminish the endothelial function, procoagulant changes in endothelial cells with promotion of platelet adhesion and reduced fibrinolysis, and promotion of beta cell apoptosis and insulin resistance. Pharmacologic agents that inhibit AGE formation or block their receptors are used to treat type 2 diabetes. Chronic intracellular hyperglycemia causes shunting of excess intracellular glucose into the hexosamine pathway and leads to O-linked glycosylation of several proteins with alterations in signal transduction pathways and oxidative stress. The O-linked attachment of N-acetylglucosamine on serine and threonine residues of nuclear and cytoplasmic proteins is associated with insulin resistance, oxidative stress, and vascular complications of diabetes. Microvascular disease. Diabetic microvascular complications, diseases in capillaries, are a leading cause of blindness, end-stage kidney failure, and various neuropathies. Characteristics of diabetic microangiopathy include occlusion of capillaries with thickening of the capillary basement membrane, endothelial cell hyperplasia, thrombosis, and parasite degeneration. Hypoxia and ischemia accompany microvascular disease, especially in the eye, kidney, and nerves. The frequency and severity of lesions appear to be proportional to the duration of the disease and the status of glycemic control. Many individuals with type 2 diabetes present with microvascular complications because of the long duration of asymptomatic hyperglycemia that generally precedes diagnosis. This underscores the need to screen for diabetes. Microvascular disease. Diabetic microvascular complications. Disease in capillaries are leading cause of blindness, end-stage kidney failure, and various neuropathies. Characteristics of diabetic microangiopathy include occlusion of capillaries with thickening of the capillary basement membrane, endothelial cell hyperplasia, thrombosis, and parasite degeneration. Hypoxia and ischemia accompany microvascular disease, especially in the eye, kidney, and nerves. The frequency and severity of lesions appear to be proportional to the duration of the disease, more than 10 years, and the status of glycemic control. Many individuals with type 2 diabetes present with microvascular complications because of the long duration of asymptomatic hyperglycemia that generally precedes diagnosis. This underscores the need to screen for diabetes. Your diabetic retinopathy. Diabetic retinopathy is a leading cause of blindness worldwide. The retina is the most metabolically active structure per weight of tissue in the body. Thus, the retina is a vulnerable target for neurovascular disease and diabetes. In comparison to type 1 diabetes, retinopathy seems to develop more rapidly in individuals with type 2 because of the likelihood of long-standing hyperglycemia before diagnosis. Most individuals with diabetes will eventually develop retinopathy, and they also are more likely to develop cataracts and glaucoma. Diabetic retinopathy results from damage to retinal blood vessels and red blood cells, platelet aggregation, relative hypoxemia, and hypertension. 3 stages of retinopathy lead to loss of vision: non-proliferative, characterized by thickening of the retinal capillary basement membrane and an increase in retinal capillary permeability, vein dilation, microaneurysm formation, and superficial and deep-root hemorrhages. Your pre-proliferative, a progression of retinal ischemia with areas of poor perfusion that culminate in infarcts, and proliferative, the result of neovascularization, angiogenesis, and fibrous tissue formation within the retina or optic disc. Traction of the new vessels on the vitreous humor may cause retinal detachment or hemorrhage into the vitreous humor with severe blurring or loss of vision. Macular edema is the leading cause of visual impairment among persons with diabetes. Blurring of vision also can be a consequence of hyperglycemia and sorbitol accumulation in the lens. Dehydration of the lens, aqueous humor, and vitreous humor also reduces visual acuity, in addition to the ocular vasculopathy associated with hyperglycemia, activation of inflammatory cells, and release of inflammatory mediators contribute to chronic neuroinflammation with injury to retinal sensory cells and loss of vision. Cataracts and defects in the eye muscle function also are associated with chronic complications of hyperglycemia and diabetes. So here you see the pathophysiology of a diabetic retinopathy. I'll leave that up for just a moment. So here you see the proliferative diabetic retinopathy. And here you see findings in diabetic retinopathy, the stages. So diabetic kidney disease is the most common cause of chronic kidney disease and end-stage kidney disease. Roughly 50% of individuals with diabetes develop diabetic kidney disease. Your hyperglycemia leads to the activation of the pyrrole pathway, the hexosamine or hexosamine pathway, protein kinase C, and inflammation, and the production of advanced glycation end products, your AGEs, all contribute to kidney tissue injury. Yet the exact process responsible for destruction of the kidneys in diabetes is not clear. Your glomeruli are injured by protein denaturation, hyperglycemia with high renal blood flow, your hyperinfiltration or hyperfiltration, the activation of the renin-angiotensin system and production of angiotensin II, resulting in intraglomerular hypertension exacerbated by systemic hypertension. Renal glomerular changes can occur early in diabetes mellitus and occasionally may precede the overt manifestations of the disease. Progressive changes include glomerular enlargement, glomerular basement membrane thickening with proliferation of mesangial cells, and proliferation of the mesangial matrix. Later in the disease, this results in diffuse and nodular glomerular sclerosis, your Kimmelstein-Wilson nodule, loss of podocytes, resistance to glomerular capillary blood flow, and decreased glomerular filtration rates. Alterations in glomerular membrane permeability occur with loss of negative charge and albuminuria. Tubular and interstitial fibrosis contributes to loss of function. The proximal tubule is particularly vulnerable because of its aerobic metabolism and high energy requirements. Your microalbuminuria is the first manifestation. Diabetic kidney dysfunction and develop within 5 to 10 years of disease. Before proteinuria, no clinical signs or symptoms of progressive glomerular sclerosis are likely to be evident. Later, hypoproteinemia, reduction in plasma oncotic pressure, fluid overload, anasarca, and hypertension may occur as renal function continues to deteriorate. Individuals with type 1 diabetes may experience hypoglycemia, which necessitate a decrease in insulin therapy as the glomerular filtration rate drops below 10 ml per minute. Uremic signs such as nausea, lethargy, acidosis, anemia, and uncontrolled hypertension occur. Glomerular filtration rate can decline independently of albuminuria, particularly in type 1 diabetes. Microalbuminuria is strongly correlated with morbidity and mortality from cardiovascular disease, particularly in type 2 diabetes. Early diagnosis and control of hypertension and hyperglycemia decrease the severity of nephropathy and delay the onset of end-stage kidney disease. The development of more sensitive tests has permitted the detection of microalbuminuria. Earlier intervention with tight glucose control and angiotensin-converting enzymes inhibitors or angiotensin II receptor blockers can reduce proteinuria and slow the progression of nephropathy. Newer agents are being evaluated, including renin inhibitors or aldosterone blockers, and anti-inflammatory agents. Aggressive treatment of hypertension is another therapeutic intervention, definitively shown to decrease albuminuria of established renal disease, but it has not reduced progression to end-stage renal disease and the need for renal replacement therapy. Your diabetic neuropathies. Diabetic neuropathy is the most common cause of neuropathy in the Western world and is probably the most common complication of diabetes. Nerves do not require insulin for glucose transport and are particularly vulnerable to the pathologic effect of chronic hyperglycemia. Peripheral neuropathy affects up to 50% of individuals with diabetes and is more common in type 2 diabetes. The American Diabetes Association has published a guideline to assist clinicians with the prevention and diagnosis of management of diabetic neuropathy. The underlying pathologic mechanism includes both metabolic and vascular factors related to chronic hyperglycemia with inflammation, ischemia, oxidative stress, advanced glycation, and end products, and increased formation of polyols, contributing to demyelation, nerve degeneration, and delayed conduction. The earliest morphologic change is axonal degeneration that preferentially involves sensory nerve fibers, particularly the smaller polymodal unmyelinated peripheral C fibers and the larger myelinated A fibers. The metabolic activation of Schwann cells is disturbed, causing segmental loss of myelin and a characteristic pattern of demyelation, and remyelination observed in long-term diabetic neuropathy. Nerve degeneration begins in the periphery, but the pathologic condition also can include the spinal cord and the posterior root ganglia. These changes may occur alone or in combination. Both somatic and peripheral nerve cells show diffuse or focal damage, resulting in polyneuropathy. Sensory deficits generally precede motor involvement. The extremities are involved first in a stocking and glove pattern. So here you see the multifactorial pathogenesis of diabetic neuropathy. The yellow boxes represent the consequences of chronic hyperglycemia. Distal symmetric polyneuropathy, sensory, autonomic, and motor nerve involvement, is the most common neuropathy with involvement of both large and small nerve fibers. Loss of small nerve fiber function include neuropathic pain and loss of sensation, and carries high risk for development of foot ulceration with subsequent gangrene and amputation. Large nerve fibers involvement result in sensory loss of proprioception and vibration with ataxia, loss of coordination, and risk for falls and fractures. Motor involvement is less common and occurs later in the disease, with weakness and muscle atrophy, particularly in the lower legs and feet. So here you see the neuropathies, and I'll leave that up for just a moment. The autonomic neuropathies can occur early, affecting gastrointestinal, enteric nerves, bladder and sexual function, sweating and body temperature regulation. Cardiovascular autonomic neuropathy is a serious complication with the heart rate, variability, changes in baroreceptor reflexes, postural hypotension, dysrhythmias, exercise intolerance, painless myocardial infarction, and sudden death. Alterations in cognitive function and increased risk for dementia may accompany long-term complications in the brain, particularly in persons with type 2 diabetes. The specific neurodegenerative mechanism is not clear. The Charcot neuroarthropathy is a progressive degenerative and structural disorganization of a joint, particularly in the foot and ankle of individuals affected by long-term diabetes. The pathogenesis may be related to inflammation, loss of sensation, neurally mediated vascular alterations with osteoclastic bone resorption. Your macrovascular disease. Diabetic macrovascular disease increases morbidity and mortality and increases risk for hypertension, accelerated atherosclerosis, cardiovascular disease, stroke, and peripheral vascular disease, particularly among individuals with type 2 diabetes. Children with poorly controlled diabetes, particularly type 2, have high risk for macrovascular disease within the first 2 decades. Unlike microangiopathy, atherosclerotic disease is unrelated to the severity of diabetes and is often present in those with insulin resistance and impaired glucose tolerance. The premature atherosclerosis of diabetes has many contributing factors, including hyperinsulinemia, hyperglycemia, hypertriglyceridemia, low levels of high-density lipoprotein, high levels of low-density lipoprotein, lipoprotein oxidation, and platelet abnormalities, advanced glycosylated end products attached to the receptor in the walls of the blood vessels, promoting oxidative stress, inflammation, endothelial and vascular smooth muscle dysfunction, and thrombosis. The process tends to be more severe and accelerated with the presence of other risk factors, including hyperlipidemia, hypertension, and smoking. So here we see all the different risk factors for endothelial dysfunction. Hit pause if you want to see that figure as a whole, but we're going to keep moving. Cardiovascular disease. Cardiovascular disease is the ultimate cause of death in up to 68% of people with diabetes, with higher risk for women. Hypertension, often coexists with diabetes, is more prevalent than in the non-diabetic population and can have many causes rather. In type 1 diabetes, hypertension is associated with a development of microalbuminuria, and type 2 hypertension is associated with metabolic syndrome. Hypertension increases the risk for coronary artery disease and stroke. Your CAD is most common cause of morbidity and mortality in individuals with diabetes. In general, the prevalence of coronary artery disease, with the duration but not the severity of diabetes and the onset, can be silent. Myocardial infarction is the cause of death of up to 75% of those with diabetes. Individuals with diabetes have a higher mortality during the acute phase of myocardial infarction than do non-diabetic individuals because they are often asymptomatic as a result of sensory and autonomic neuropathy. Guidelines have been developed to reduce the risk and improve treatment of cardiovascular and coronary artery disease in individuals with diabetes. The incidence of congestive heart failure is higher in individuals with diabetes, even without myocardial infarction. This may be related to oxidative stress, pro-inflammatory factors that result in myocardial remodeling, and cardiomyopathy, with increased amounts of collagen in the ventricular wall and ventricular hypertrophy. There is reduced mechanical compliance of the heart during filling, with diastolic and eventually systolic failure. Your stroke is twice as common in those with diabetes, as is in a non-diabetic population, and more common in diabetic women. Ischemic and lacunar stroke are more common than hemorrhagic stroke and may be related to autonomic nervous system, neuropathy-associated atrial fibrillation, and platelet coagulation, in addition to other risk factors. The survival rate for an individual with diabetes after a massive stroke is typically shorter than that of a non-diabetic individual. Hypertension, hyperglycemia, hyperlipidemia, thrombosis, and sleep apnea are risk factors, and aggressive management of blood pressure, hyperglycemia, and lipidemia in individuals with diabetes has been shown to reduce the incidence of stroke. Your peripheral artery disease, your peripheral vascular disease, is an atherosclerotic occlusion disease of the lower extremity. Diabetes increases the incidence of peripheral artery disease with claudication, ulcers, gangrene, and amputation. Age, duration of diabetes, glycemic control, genetics, and additional risk factors. Your smoking, hyperlipidemia, and hypertension influence the development and management of peripheral artery disease. Occlusion of the small arteries and arterioles, particularly below the knee, cause most of the gangrenous changes of the lower extremities and occur in patchy areas of the feet and toes. The lesions begin as ulcers and progress to osteomyelitis or gangrene, requiring amputation. Peripheral neuropathies and increased risk for infection advance the disease. The following figure illustrates how foot lesions of diabetes can lead to amputation. Significant morbidity and mortality are associated with major amputation. So here we see diabetes, angiopathy, and neuropathy. How foot lesions of diabetes can lead to an amputation. So I'll leave that up for just a moment. Again, you can hit pause. This way you can see it a bit longer. Infection. Increased morbidity and mortality from infectious agents have been documented in those with diabetes. The individual with diabetes is at increased risk for infection for several reasons. The senses, impaired vision, caused by retinal changes, and impaired touch, caused by sensory neuropathy, lead to loss of protection with injury. Hypoxia, when skin integrity is compromised. Tissues' susceptibility to infection increases as a result of vascular disease and hypoxia. In addition, the glycosylated hemoglobin in red blood cells impedes the release of oxygen to tissues. Your pathogens. Some pathogens proliferate rapidly because of increased levels of glucose in body fluids, which provides an excellent source of energy. Blood supply. Decreased blood supply result from vascular changes and autonomic dysfunction, which decreases the supply of white blood cells to the affected area. Suppressed immune response. Chronic hyperglycemia impairs both the innate and the adaptive immune response, including abnormal chemotaxis, vasoactive responses, and defective phagocytosis. Clinical signals of infection may be absent. Your delayed wound healing, slower collagen synthesis, and decreased angiogenesis. increase the opportunity for infection. The risk of infection is especially high for individuals who take immunosuppressant medications, who have comorbidities, or who are undergoing surgery. Your alterations of the adrenal function, disorders of the adrenal cortex. Disorders of the adrenal cortex are related to either hyperfunction or hypofunction, just like all the others here in our list. Your hyperfunction that causes increased secretion of cortisol, hypercortisolism, leads to Cushing's syndrome or Cushing's disease. Hyperfunction that causes increased secretion of adrenal androgens and estrogens leads to viralization or feminization. Hyperfunction of that causes increased levels of aldosterone leads to hyperaldosteronism, which may be primary or secondary. These syndromes often have overlapping features. Hypofunction of the adrenal cortex leads to Addison's disease. So hypercortical function, or Cushing disease, or Cushing syndrome. Cushing syndrome refers to the clinical manifestation resulting from chronic exposure to excess endogenous cortisol and is more common in women. Cushing's disease refers to excess endogenous secretion of ACTH, corticotropin. ACTH-dependent hypercortisolism results from overproduction of pituitary ACTH by the pituitary adenoma, or by an ectopic secreting non-pituitary tumor, such as a small cell carcinoma of the lung. ACTH-independent hypercortisolism is caused by cortisol secretion from a rare benign or malignant tumor of one or both adrenal glands. A Cushing-like syndrome may develop as a side effect of long-term pharmacologic administration of glucocorticoids. So what's the pathophysiology? With ACTH-dependent hypercortisolism, the excess ACTH stimulates excess production of cortisol, and there is loss of feedback control of ACTH secretion. Whatever the cause, two observations consistent apply to individuals with Cushing syndrome. They do not have diurnal or circadian secretion patterns of ACTH and cortisol, and two, they do not increase ACTH and cortisol secretion in response to a stressor. In individuals with ACTH-dependent hypercortisolism, secretion of both cortisol and adrenal androgens is increased, and corticotropin-releasing hormone secretion is inhibited. ACTH-independent secreting tumors of the adrenal cortex, however, generally secrete only cortisol. Elevated cortisol levels suppress CRH and ACTH secretion from the hypothalamus and anterior pituitary, respectively, which leads to a low level of ACTH. A low level of ACTH causes atrophy of the remaining normal portions of the adrenal cortex, which over time will alter the cortisol secreting activity of normal cells. When the secretion of cortisol by the tumor exceeds normal cortisol levels, symptoms of hypercortisolism will develop. So clinical manifestations. Weight gain is the most common feature and result from the accumulation of adipose tissue in the trunk, facial, and cervical areas. These characteristics of fat deposition have been described as truncal obesity, moon face, and a buffalo hump. Transient weight gain from sodium and water retention may be present because of the mineralocorticoid effects of cortisol, exhibited when cortisol is present in high levels. So here we're doing a comparison of Addison's disease and Cushing syndrome. Again, Cushing syndrome, a patient before the onset of Cushing syndrome and 4 months later. Glucose intolerance occurs because of cortisol-induced insulin resistance and increased gluconeogenesis and glycogen storage by the liver. Overt diabetes mellitus develops in approximately 20% of individuals with hypercortisolism. Polyuria is a manifestation of hyperglycemia and resultant glycosuria. Protein wasting is caused by the catabolic effect of cortisol on peripheral tissues. Muscle wasting leads to muscle weakness and is especially obvious in the muscles of the extremities. The thinning of the limbs. In bone, loss of protein matrix and increase in bone resorption lead to osteoporosis and can result in pathologic fractures, vertebral compression fractures, bone and back pain, kyphosis, and reduced height. Hypercalciuria may result in renal stones, which are experienced by approximately 20% of individuals with this disease. Loss of collagen also leads to thin, weakened integumentary tissues through the capillaries are more visible. The tissues are easily stretched by adipose deposits. Together, these changes account for the characteristic purple striae most often observed in the truncal area. Loss of collagenous support around small vessels makes them susceptible to rupture, leading to easy bruising, even with minor trauma. Thin, atrophied skin is also easily damaged, leading to skin break and ulceration. Bronze and brownish hyperpigmentation of the skin, mucous membrane, and hair occurs when there are very high levels of ACTH. This is caused by increased levels of melanocyte-stimulating hormone resulting from excess conversions of pro-opiomelanocortin, and ACTH concentration is elevated. With elevated cortisol levels, vascular sensitivity to catecholamines is increased significantly, leading to vasoconstriction and hypertension. Metabolic syndrome with abdominal obesity, hypertension, glucose intolerance, and dyslipidemias is a common complication. Individuals with hypercortisolism are at increased risk for cardiovascular complication, CAD, heart failure, and stroke. Chronically elevated cortisol levels also cause suppression of the immune system, increased susceptibility to infection, and poor wound healing. Approximately 50% of individuals with hypercortisol, hypercortical, oh my goodness, hypercortisolism experience alterations in their mental status caused by the effects of cortisol on hippocampal neurons and the subsequent implications on learning, memory, and other neurologic functions when cortisol levels are elevated. These may range from irritability and depression to severe psychiatric disturbances such as schizophrenia, which improve with treatment. Females may experience symptoms of increased adrenal androgen levels, increased hair growth, especially facial hair, acne, and oligomenorrhea. Rarely do androgen levels become high enough to cause change of the voice, recession of the hairline, and hypertrophy of the clitoris, unless a adrenal carcinoma is involved. Infertility is more common among women. So are evaluation and treatment. A variety of laboratory tests must be used to diagnose hypercortisolism, to determine the underlying disorder and differentiate ACTH-dependent from ACTH-independent Cushing syndrome. These tests include urinary and serum cortisol and serum ACTH concentration. Other tests include the dexamethasone suppression test and bilateral inferior petrosal sinus sampling. Late-night salivary cortisol levels are used as a screening test and to document alterations in the diurnal variation of cortisol level. Routine lab exams may reveal hyperglycemia, glycosuria, hypokalemia, and metabolic alkalosis. Tumors are diagnosed using imaging procedures. Treatment is specific for the cause of hypercorticoadrenalism and include medication, radiation, and surgery. Differentiation among pituitary, ectopic, and adrenal causes is essential for effective treatment. Without treatment, approximately 50% of individuals with Cushing syndrome die within 5 years of onset as a result of overwhelming infection, suicide, complications from generalized arteriosclerosis, and hypertensive disease. Guidelines are available for the treatment of Cushing syndrome. Congenital adrenal hyperplasia. Congenital adrenal hyperplasia is an autosomal recessive disorder that causes deficiency of an enzyme that is critical in cortisol biosynthesis. Because cortisol production is low, ACTH concentration increases, causes trophic adrenal hyperplasia. The most common form is the 21-hydroxylase deficiency. That's 90%. That results in both mineralocorticoid and glucocorticoid deficiency and adrenal androgen synthesis. Affected female infants are viralized, and infants of both sexes exhibit salt wasting. Neonatal screening includes the measurement of 17-hydroxyprogesterone. Treatment includes avoidance of glucocorticoid overtreatment and management of sex steroid excess. Your hyperaldosteronism. Hyperaldosteronism is characterized by excessive aldosterone secretion by the adrenal cortex. There are both primary and secondary forms of hyperaldosteronism. Primary hyperaldosteronism, Conn syndrome, is caused by excessive secretion of aldosterone from an abnormality of the adrenal cortex. Your secondary hyperaldosteronism involves excessive aldosterone secretion from an extra-adrenal stimulus. So what is our pathophysiology? Your primary hyperaldosteronism, Conn syndrome, is usually the result of a unilateral benign aldosterone-producing adrenal adenoma. Bilateral adenoma, nodular hyperplasia, and adrenal carcinomas account for the remainder of the case. The incidence is estimated to be 10% of all hypertensive individuals. However, approximately 33% of people with resistant hypertension will have evidence of primary hyperaldosteronism. Excessive autonomous secretion of aldosterone without its principal regulator, angiotensin II, causes hypokalemia and induces insulin resistance, promotes inflammation, endothelial dysfunction, and cardiovascular remodeling, and affects adipose tissue differentiation and function. Thus, primary hyperaldosteronism can influence the features of the metabolic syndrome, including hypertension, obesity, dyslipidemia, insulin resistance, and hyperglycemia. Your secondary hyperaldosteronism involves excess aldosterone secretion from the action of angiotensin II through the renin-dependent mechanism. Examples include decreased circulation, blood volume, and decreased delivery of blood to the kidneys. Here, the activation of the renin-angiotensin system and subsequent aldosterone secretion may be seen as compensatory, although in some instances, the increased circulating volume further worsens the condition. Other causes of secondary hyperaldosteronism are Bartter syndrome, a renal tubular defect causing hypokalemia, and renin-secreting tumors of the kidneys. So there are some physiologic factors affecting renin and aldosterone secretion: your age, menstrual cycle, sodium intake, potassium status, your posture, sympathetic nervous system, and time of sampling. Your clinical manifestations. The classics: hypertension, hypokalemia, and hypervolemia because of increased sodium reabsorption, without the peripheral edema though, and metabolic alkalosis. are hallmark of hyperaldosteronism. Hypertension is resistant to treatment and may result from increased intravascular volume from a state of aldosterone-mediated vasoconstriction. Although the latter mechanism requires very high levels of aldosterone, if hypertension is sustained, the long-term effects of elevated arterial pressure become evident, which include the development of left ventricular dilation and hypertrophy, vascular disease, and renal disease. In primary hyperaldosteronism, renin secretion is typically suppressed because of the autonomous production of aldosterone. Although it is elevated in secondary hyperaldosteronism, which provides a means to clearly differentiate between the two conditions, edema usually does not occur with primary aldosteronism. Sodium loss and water loss are maintained by hypervolemia-induced atrial natriuretic factor release, pressure natriuresis, and aldosterone escape. The escape phenomenon changes or resets the rate of sodium excretion in the proximal tubules and prevents more severe sodium retention. Although the mechanism provides protection from excess sodium reabsorption and edema, it can increase urinary losses of potassium and cause hypokalemia. Aldosterone-stimulated potassium loss can be variable. Serum potassium levels less than 3.0 result in typical manifestations of hypokalemia. Hypokalemia metabolic alkalosis is caused by the movement of potassium from the intercellular to extracellular space in exchange for hydrogen ions, as well as renal loss of hydrogen ions to facilitate sodium reabsorption. So our evaluation and treatment. Various clinical and lab measures are useful in the assessment of hyperaldosteronism and include the following. A measurement of blood pressure. Hypertension is usually present. Serum or urinary electrolyte levels. Serum sodium level is normal or slightly elevated. Serum potassium level is normal or depressed, and urinary potassium level is elevated. Metabolic alkalosis may be present. Plasma aldosterone to renin ratio increases. Aldosterone suppressing testing is performed using either salt loading or fludrocortisone acetate if the aldosterone to renin ratio is increased. Imaging techniques may be used to localize an aldosterone-secreting adenoma. Serum aldosterone and plasma renin activity both must be measured under controlled situation and after careful dietary regulation of sodium and potassium intake, and withdrawal of hypertensive agents if feasible. The following table summarizes normal physiologic factors that affect renin and aldosterone secretion. Imaging techniques such as CT and nuclear magnetic resonance (NMR) may be used to localize an autonomous aldosterone-secreting adenoma. Sampling from both adrenal veins also may be useful. Renography can be used to diagnose secondary hyperaldosteronism. Treatment includes management of hypertension and hypokalemia, as well as correction of any underlying causal abnormality. If an aldosterone-secreting adenoma is present, it is generally approached surgically. Medical management with aldosterone receptor antagonists, such as spironolactone and eplerenone, is a viable option in selecting cases. Angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and revascularization procedures for renal artery stenosis are used to treat secondary hyperaldosteronism. Your hypersecretion of adrenal androgens and estrogens. Hypersecretion of adrenal androgens and estrogens may be caused by adrenal tumors, either adenomas or carcinomas, endogenous hypercortisolism, or defects in steroid synthesis, The clinical syndrome that is manifested depends on the hormone secreted, the sex of the individual, and the age at which the hypersecretion is initiated. Hypersecretion of estrogen causes feminization, the development of female sex characteristics. Hypersecretion of androgen causes virilization, the development of male sex characteristics. So here you see virilization of a young girl by an androgen secreting tumor of the adrenal cortex. The masculine features include lack of breast development, increase in muscle bulk, and hirsutism. The effects of an estrogen secreting tumor are most evident in males and result in gynecomastia, testicular atrophy, and decreased libido. In female children, such tumors may lead to early development of secondary sex characteristics. The effects of an androgen-secreting tumor are more easily observed in females and include excessive face and body hair growth, hirsutism, clitoral enlargement, deepening of the voice, amenorrhea, acne, and breast atrophy. In children, virilizing tumor promote precocious sexual development and bone aging. Treatment of androgen-secreting tumors usually involve surgical excision. Adrenocortical hypofunction, hypocorti- hypocortisolism, or low levels of cortisol secretion, can be primary, secondary, or tertiary. Your primary, your Addison's disease, develops because of the primary inability of the adrenals to produce and secrete the adrenocortical hormones. Secondary hypocortisolism develops because of inadequate stimulation of adrenal glands by ACTH. Sometimes there is a partial dysfunction of the adrenal cortex, so only synthesis of cortisol or aldosterone or the adrenal androgen is affected because the adrenal cortex has three distinct zones, which secrete the various hormones. Tertiary hypocortisolism is commonly caused by abrupt withdrawal of exogenous glucocorticoids, or as a complication of treatment for Cushing syndrome. High levels of glucocorticoids decrease hypothalamic corticotropin-releasing hormone synthesis and secretion, and also block the trophic and ACTH secretagogue action of CRH on anterior pituitary cells, resulting in loss of ACTH and its actions on the adrenal gland. Symptoms and management are similar to those for secondary hypocortisolism. Your primary adrenal insufficiency, hypocortisolism, and hypoaldosteronism is often termed Addison's disease. Addison's disease is relatively rare, occurring most often in adults 30 to 60 years of age, although it may appear at any time. The most common cause of Addison's disease in the US is autoimmune destruction of adrenal cortex. It is more common in women. Other causes include infections, tuberculosis, fungal infections, HIV, infiltrative diseases, amyloidosis, metastatic carcinoma, or bilateral adrenal hemorrhage. Adrenoleukodystrophy and adrenomyeloneuropathy are two rare types of X-linked adrenal deficiencies that lead to symptoms of hypocortisolism and progressive neurologic symptoms. Pathophysiology. Addison's disease is characterized by inadequate corticosteroid and mineralocorticoid synthesis and elevated serum ACTH levels. Loss of negative feedback. Before clinical manifestations of hypocortisolism are evident, more than 90% of total adrenocortical tissue must be destroyed. Idiopathic Addison's disease causes adrenal atrophy and hypofunction and is an organ-specific autoimmune disease. It may occur in childhood or adulthood. Your 21-hydroxylase autoantibodies and autoreactive T cells specific to adrenal cortical cells are present in 50 to 70% of individuals with idiopathic Addison's disease. This percentage increases in younger persons and in those with an autoimmune disease. This deficiency allows proliferation of immunocytes directed against specific antigens within the adrenocortical cells. The adrenal glands in idiopathic Addison's disease are smaller than normal and may be misshapen. Several genes have been identified. Idiopathic Addison's disease often is associated with other autoimmune diseases, and in such cases is known as autoimmune polyendocrine syndrome, or APS. APSI, or type 1, is inherited as autosomal recessive with childhood onset and includes Addison's disease, hypoparathyroidism, mucocutaneous candidiasis, and other less common symptoms. APS2 is more common and involves Addison's immune thyroid disease, diabetes, celiac, and hypogonadism. So what are our clinical manifestations? What do these patients look like? The symptoms of Addison's disease are primarily a result of hypocortisolism and hypoaldosteronism and are often vague and not well defined. With mild to moderate hypocortisolism, symptoms usually begin with weakness and easy fatigability. Skin changes, including hyperpigmentation and vitiligo, may occur. As the condition progresses, anorexia, nausea, vomiting, and diarrhea may develop. Symptoms of mineralocorticoid deficiency include hypovolemia, postural hypotension, and dizziness, dehydration, hyperkalemia, and salt craving. Of greatest concern is the development of hypotension that can progress to complete vascular collapse and shock. This is known as adrenal crisis or Addisonian crisis and develops with undiagnosed disease, acute withdrawal of glucocorticoid therapy, or the occurrence of infection or other comorbid stressful events. Decreased adrenal androgen secretion is usually not clinically obvious in men because the adrenals are not a major source of male androgens. However, hypogonadism can occur. Women may experience loss of some secondary sexual characteristics, such as pubic and axillary hair, normally maintained by the adrenal androgens. Some studies also have reported an associated low-function ovarian reserve. Disturbances in mood and motivation are common, and symptoms of Addison's disease are summarized here in the following table. As always, hit pause if I'm going too quickly through this. But the big ones are weakness, easy fatigability, gastrointestinal disturbances, hypoglycemia, hyperpigmentation, vitiligo, and Addisonian crisis, severe hypotension and vascular collapse. Our evaluation and treatment, therefore, your serum urine levels of cortisol are depressed with primary hypocortisolism, and ACTH levels are increased because dehydration, blood urea nitrogen levels may increase, serum glucose concentration is low, your eosinophil and lymphocyte counts are often elevated. Hyperkalemia is seen in Addison's disease and may cause mild metabolic alkalosis. Your ACTH stimulation, short test, may be used to evaluate serum cortisol levels, or, if not possible, the measurement of morning plasma, ACTH, and cortisol levels. Measurements of serum 21-hydroxylase, autoantibodies, and a baseline serum 17-hydroxyprogesterone level also may be diagnostic. The treatment of Addison disease involves lifetime glucocorticoid and mineralocorticoid replacement therapy, together with dietary modifications and the correction of any underlying disorder. Efforts are in progress to replace cortisol in a physiologic manner using modified release formulation of hydrocortisone. With acute stressors, additional cortisol must be administered to approximate the amount of cortisol that might be expected to be secreted if normal adrenal function were present. And this is called stress dosing. The individual's diet should include at least 150 milligram MEq of sodium per day, with sodium intake increased in the event of excessive sweating or diarrhea. Your secondary hypocortisolism. Secondary hypocortisolism commonly results from prolonged administration of exogenous glucocorticoids and effective treatment of endogenous hypercortisolism. The consequence is suppression of ACTH secretion that causes adrenal atrophy and results in inadequate corticosteroidogenesis. Once the exogenous glucocorticoids are withdrawn, decreased ACTH secretion also can result from pituitary infarction, pituitary tumors that compress ACTH secreting cells, or hypophysectomy. In all instances of low ACTH levels, adrenal atrophy occurs and endogenous adrenal steroidogenesis is depressed. Clinical manifestations of secondary hypocortisolism are similar to those of Addison's disease, although hyperpigmentation usually does not occur because melanocyte-stimulating hormone is also deficient. The renin-angiotensin system usually is normal, so aldosterone and potassium levels also tend to be normal, and hypotension is less prominent. Recovery of adrenal function is possible with correction of the primary problem. Tumors of the adrenal medulla. Hyperfunction of the adrenal medulla is caused by pheochromocytomas or sympathetic paragangliomas of the adrenal medulla that continuously secrete catecholamines, your norepinephrine and epinephrine. These are rare neuroendocrine tumors and are usually sporadic, although up to 40% of them can be inherited. Familial forms are associated with mutation in the neurofibromatosis type 1 gene, von Hippel-Lindau gene, and multiple endocrine neoplasia types. 2. Any of the succinate dehydrogenase complex subunit genes can lead to pheochromocytoma and paragangliomas. About 10% to 20% of the pheochromocytomas are malignant. Those that are malignant metastasize to lungs, liver, bones, and your para-aortic lymph nodes. Juicy. That is a picture of a pheochromocytoma. The pathophysiology. Your pheochromocytoma and sympathetic paragangliomas cause uncontrolled production of norepinephrine, although large tumors also secrete epinephrine. Roughly 5% of people with pheochromocytoma have no symptoms, because the tumor appears to be non-functioning. Such tumors can, however, release catecholamines in response to stressors, such as surgery. So our clinical manifestations. The clinical manifestations of a pheochromocytoma and sympathetic paraganglioma are related to the chronic effects of catecholamine secretion and can include persistent hypertension, headache, sweating, palpitations, tachycardia, palpitations, some more palpitations, and pallor. Hypertension results from the increased peripheral vascular resistance and may be sustained or paroxysmal. An acute episode of hypertension related to hypersecretion of catecholamines may follow specific events, such as exercise, excessive ingestion of tyrosine containing foods, your cheese, wine, beer, and yogurt. Ingestion of caffeine foods, external pressure on the tumor, and induction of anesthesia. Hypertension, unresponsive to drug therapy, is often the first indication of a pheochromocytoma. Headaches appear because of sudden changes in catecholamine levels in the blood, affecting cerebral blood flow. Hypermetabolism and sweating are related to chronic activation of sympathetic receptors in adipocytes, hepatocytes, and other tissues. Glucose intolerance may occur because of catecholamine-induced inhibition of insulin release by the pancreas. Complaints of warmth, heat intolerance, weight loss, and constipation are common despite a normal or increased appetite. These tumors tend to be extremely vascular and can rupture, causing massive and potentially fatal hemorrhage. Your evaluation and treatment, therefore. Your symptoms of pheochromocytoma can be insidious or intermittent and difficult to diagnose. A diagnosis of pheochromocytoma is made when increased catecholamines are found in the blood or urine. Plasma-free metanephrines and urinary fractionated metanephrine levels are highly sensitive diagnostic indicators when these laboratory techniques are available. The site of the tumor is determined using abdominal imaging techniques because of the possibility of metastasis. Whole body scanning may be done. Genetic testing is commonly complicated and can guide therapy. Management of catecholamines excess is essential to prevent hypertensive emergencies and require the use of alpha and beta adrenergic blockers and calcium channel blockers that are typically initiated several weeks before surgery. The usual treatment of a pheochromocytoma is laparoscopic surgical excision of the tumor, although open resection is still completed for large tumors or when metastasis is suspected. Medical therapy is continued to stabilize blood pressure during, before, and after surgery. Malignant pheochromocytoma is rarely curable and is usually managed by a combination of surgical debulking of the tumor combined with chemotherapy. And that does it for us. This concludes chapter 22, Alterations of Hormonal Regulation. Whew, that sure was a doozy. Not gonna lie, wasn't expecting quite that much. But we'll see you with the next chapter. So we thank you as always for watching and have a good day.